All right, and we're on. So we're doing the upper extremity. Notice there's part one. Okay, so there's a sequel to this film. So I guess it did well in box office the first time around. So make part two. All right, so we'll make a. So here's how it's gonna be set up. Um, Literally part one, part two, upper extremity. Then they're gonna do like a prequel called lower extremities, part one and part two. Okay, so lots to cover, lots to do. Here are your instructional objectives in case you need to understand what we're doing. All right, so when we look at any patient, we need to get familiar with the surface anatomy. And what I mean by that is when you look at it, say someone's complaining about their shoulder, you need to understand what you're looking at. You can't just be like, I see a shoulder, but I don't know where the acromion is, I don't know where the coracoid process is, I don't know where the clavicle is, I don't know what muscle inserts where. And that's a problem because you need to know that stuff, okay? You have a good foundation of anatomy in order to help someone with pathology. If their shoulders are pointing to a specific area, you're like, oh man, well, what is there? I don't know. And you're kind of trying to play it off. They're going to know. So you understand your stuff. So, like I've always told you, with anatomy this semester, we got to categorize things or compartmentalize things. You know, upper third, middle third, you know, proximal, middle, distal. This is how we're going to categorize the upper extremity. So when I say upper extremity, it involves your shoulder girdle, meaning your humerus, your scapula, your clavicle, all the way down to their distal humerus, your radius ulna, carpal bones, metacarpals, and phalanges. That is an upper extremity, and you have two of them. Okay. So bilateral is a term we use when someone's complaining of, if someone has bilateral shoulder pain, that's the term we use. Got a 37-year-old patient, right hand dominant. Anytime you're describing an upper extremity injury, and please note this, you got to say what hand dominance they are. Okay, specifically if you're in the ERPA, you're consulting orthopedics, then you know what hand it is. Okay, hey ortho, I got a 37-year-old right-hand dominant gentleman with right shoulder pain, complaining of numbness down the C5 dermatome. He has an inability to abduct his right shoulder. He's complaining of neck pain. He just was in a car accident, whiplash. So see how everything you built upon this semester is used and the terminology we use, and see how easy it was for me to say that. That takes years of practice. Okay, that's how I want you guys to be. At the end of the last day here, I'm just gonna go tell me about a patient. Go. Just kidding. I won't do that to you guys. But eventually we'll get to that point, okay? Because I'll be, when you guys go on rotation, you guys will have to turn in notes, and I have to grade those notes, and I'll be able to guide you on how to improve that verbiage, that language that you guys have been taught so far. So we got 4 segments in the upper extremity. So the pectoral region, okay? It's all by regions, okay? Pectoral region, scapular region, lateral and supraclavicular regions. Okay, so we've got your pectoral girdle. So you have to know what, if I say pectoral girdle, what comprises it? Your scapula, your clavicles, and your manubrium. Okay, scapula is the only English way of describing a plural form of scapula. Okay, so that's the old English way. I notice that's going to be in anatomy as well. So if I were to ask you what comprises the pectoral girdle, what are you going to say? Okay, how many of y'all looked? Good, that's good. Take advantage. One day it'll be blocked off. All right, so sternoclavicular joints, your SC joints. Okay, so they're basically where your manubrium, your sternoclavicle all kind of coincide there. We'll go to that in a second, but that's what you need to understand your basics there. The next part is in Latin brachium, or brazo in Spanish. Brazo brachium is your humerus, your arm. And this is a good diagram here because it's kind of already labeled for you, segmented wise. So here's your arm. That's a location. So when I say arm or brachium, we're meaning humerus, okay? The next segment, the third segment, is your antebrachium. Anta for meaning anterior, correct? Anatomical position, where's the forearm? Anterior, okay? And we do this, antebrachium, so that's your forearm. So there you go. And then your hand is manus, or mano in Spanish. Manus is in Latin. That's your carpals, metacarpals, and phalanges. The carpal bones are in two rows. We'll learn that shortly. It's a proximal and a distal row. They make up your wrist joint. Multiple ligamentous structures there. Very complicated to understand and know. And we'll go that into it deeper. And then your phalanges are your actual fingers. Your metacarpals are in the middle. They end right here at your knuckles. Okay, metacarpal phalangeal joint. So I would get familiar with your surface anatomy and your four segments and what comprises of each one of them, because you will see that as a PA in the real world in any type of setting. Because you could be in a family medicine clinic. Someone's like, my shoulder hurts, and then you have to refer it out to a orthopedic or a family medicine, sports medicine person, as that extra year fellowship. This is an excellent diagram for you guys to study off of. As you can see, it's got an anterior and posterior region of each side. There on your patient right, it's showing anterior. You got everything you need to know here. Now, notice that there's anatomy of the anatomy. There's lateral epicondyles, the humerus here, medial epicondyle. Remember we discussed the greater tuberosity over here. There it is, and then your lesser one over here. And right there is where the long head of the biceps tendon travels through. We'll go over in a second. Here's your clavicle. Then posterior, what's this structure called again? The green, what's that? Spine? Yeah. Spine or scapula, correct? But there's different parts of it. There's anatomy of the anatomy, the spine of the scapula. There's a crest, and there's a root as well, okay? I need you guys to understand that as well. The medial border of the scapula, or also known as the vertebral border of the scapula, right in here. Okay, and then back here we have your olecranon process, your ulna posteriorly. So you need to understand, like put a big red circle or something around this slide, because I want you guys to understand it, okay? Kind of complies with everything we just discussed in the four segments. So there's 16 regions in addition to that. That we need to understand, and this diagram labels it very well for you. Number 2 is this little tiny triangle section here. It's like little like crevice here if y'all want to literally dig in there. That's your clavicle pectoral triangle, okay? We'll learn about that later, but it's also known as the foramen of Whitebrecht. We'll go over that later. That's where like most of the shoulder dislocations end up. Right through there, the humeral head literally busts right through that clavicle pectoral triangle. And that's what's important for you guys to know that, okay? But I would identify, this is already done for you. If you want to just like white out all the names, and then the numbers are already listed on the diagram, see there? And I want you guys to know that, okay? Because this is how you can describe things to orthopedic people on a phone call when you're consulting them. Okay, he's got pain along the clavicle pectoral triangle with obvious deformity. He fell on an outstretched right upper extremity while playing softball, sliding to second base. So what are you guys thinking happened there? Shoulder dislocation, right? Obvious deformity through the clavicle pectoral triangle. So that means that humeral head is already right through there. So this is the first 8, and then you have a legend right here. You also have a legend right here, this guy. Just joking, haha. I had to. All right, I'll stop. I'm sorry. Let's get serious. All right. You guys needed to laugh. All right, then we got the posterior side here. So anterior and posterior forearm, anterior posterior wrist, palm or palmar or volar is another term we use, volar for the hand, and dorsum, so of the hand. So when you're in the hand, I prefer volar and dorsum, okay? Palmar is just generalized medicine, but if you want to get truly down into orthopedic realms, the term volar is preferred over palmar, okay? And your digits, your fingers are called digits. So when you're writing notes, you don't say his middle finger hurts. It's either you count the numbers. Where do you go by? Do you start with the small finger as number 1? Or no? So it'll be 1, 2, third digit. Yes. Or if you want to get more specific, it's not called a middle finger, it's called a long finger. Okay? In orthopedic terminology, it's called long finger, the third digit. I've told you stories about the colleague I used to have who was not very good at notes or speaking language. He would write patients right pinky hurts. Is that appropriate? Nice. What do you say? Yeah, right fifth digit, or if you want to be more specific, right small finger. Okay, small finger. All right, or fifth digit. But digits is the term we will use. Okay. All right. So don't call them fingers anymore. Call them digits. Okay. So if you're in the hallway and you hurt your digit, you say my digit hurts. That's all you gotta say. That way you're studying. See. Okay. But yeah, know all of these regions and segments. Know them real well. And then the same thing as the surface anatomy, but now we're actually doing the bony anatomy here, okay? So it's the anterior and posterior sides. So you have certain regions here that are important, primarily for ligamentous attachment, tendon attachment, muscle attachment, and certain vectors of motion, as we will discuss. So there's 8 carpal bones. That's important to know. We'll go over that shortly. I'm going to bring in my own personal experience to the course today. This is a safe space. If you disagree, I don't care. It's a safe space. For me, it is. I don't mind sharing with you guys, okay? That's why you learn. So there's 8 carpal bones. How many carpal bones are there? 8. Okay. You have to know all of them, okay? But you'll find some fun mnemonic to remember that. There's some all over the internet that are appropriate and some are inappropriate. So you decide which one you want to use. I'm not getting into that. Okay. All right. So clavicle, obviously, that's a big bone right here. Scapula in the posterior section, humerus, ulnar radius. Your metacarpal bones, obviously, there's 5 because there's 5 digits. Yes, awesome. And your phalanges, which are another, just to make it more confusing. So surface anatomy wise, they're called digits. Okay, if you're a valiant patient. Anatomically, if you're looking at an X-ray, you're going to use the term phalanx for single digit or phalanges for total. Those are your digits, okay? So anatomically, if I'm seeing a patient, I describe it as his third digit is painful to palpation. If we're looking at an X-ray, his third phalanx appears to have an avulsion fracture at the base. Okay? Yes?
So it's only in X-ray?
Yeah. Yeah. When you're describing an X-ray or in clinical world, yeah, it'd be a phalanx. Or you can just say, but clinically, when you're writing a note and you're describing what you see on the patient, because like when I saw patients at the orthopedic walk-in clinic at Jewett, I'd be responsible. I was dictating, which was awesome. I didn't have to type or anything. Some person did it for me, which was great. It was awesome. There was a rumor that it was sent out overseas for somebody to do it for me, but they're trying to cut costs. But I don't believe that stuff. They had a transcription department there, but I don't know. You can't believe what you hear. But anyways, but yeah, I would dictate everything, and then the notes would get transcribed. They get sent to me, and they would have my automatic. When I got hired, I had to sign my name on a little pad, and that would get put on everything, so they didn't have to harass me every day for a signature. It was just done for me. But I'd have to approve the note and send it to my attending physician for him to read, and he would sign off, and that would get sent off to the insurance company for payment and all that stuff. So that's where it all begins. That's how. And if you want to get paid, you have to use the right terminology. Okay, that's how it all works. Insurance companies are real sticklers. So, well, no, he said finger, not digit. I don't know what that is. So, see what I mean? But there was a section where I had to read the radiographs myself, and that takes time to learn. But I would give a generalized report, third phalanx presents with a avulsion fracture at the base, so that would also be included in the note as well. So that is why you have to use the terms properly. Medicine is a business, unfortunately. You guys, understand that. I'm ready to tell you right now today, it's a business, guys. You have to produce. You have to see patients. If not, they don't like that. Okay, so use the proper terminology. So when do we use digits? When you're seeing patients, and I'm failing, so we'll go from there. Okay, so clavicle is the proper term for it. Collarbone is what the general population calls it. Okay, so we do not use collarbone in this class or anywhere else for the next 27 or 24 months you guys have. Whatever. But yeah, there's anatomy of the anatomy of clavicle. Okay, so its main job is to connect that appendicular arm to the trunk of the body through the sternum and the manubrium. So know which side, just by looking at it, you should be able to understand what side you're looking at. Okay, medial or lateral. Okay, so obviously the medial side is going to be a little bigger. It's going to attach to that sternum and the manubrium section there. Important to understand the shape of it, because it's going to be that medial 2/3. That's basically like this part here. See, that's convex anteriorly. Most of the time, the middle third right here, you'll see that red dot. Or no? Mm-hmm. That's where all the fractures occur, right here, middle third. Most commonly, like 90% of all clavicle fractures occur in the middle third. And on the lateral side, it connects to the scapula. So underneath there, you have what important structure that we learned that comes through there. That's a good one. What else? It's an artery. Subclavian artery, right? Yeah, you got it. Yeah. So it protects subclavian artery. So sometimes when I've seen this a few times where like traumatic, like in falls from great height, reflexively, our body, our lower brain has us do this. When we fall, our arms go out after his hand. So that force of falling from like a 2-story building and landing like this, the ground reaction, it's called ground reaction force, develops the second your body touches the ground. There's like energy already in the ground. It's all physics class again, okay, guys? So there's energy in the ground there, and then you hit yourself, and then it transmits through your arms, and kind of has to dissipate somewhere. And the weakest part is that middle third of your clavicle, so that's where the energy just goes and breaks your clavicle. And those shards, if it's a spiral fracture, it can literally sever that subclavian artery and actually kill somebody. Okay, so it's going to be very careful. That's why anything in that area you let the surgeons kind of deal with. I'm like, I ain't touching that. So, but yeah, so that goes into what we just discussed now. It transmits shock to the upper limb and everything. So it's there to kind of create like a strut. You guys know what a strut is? Like kind of like in the cars, it kind of keeps things like from closing in on each other. Because if you didn't have clavicles, your shoulders will roll over like this. That's what would happen. And there was, I think my first day at the ER rotation, I had this doctor who tried to intimidate me by having me look at a chest x-ray. So I had tunnel vision, and I was looking at just the lungs, and I didn't know what I was looking at. I was like, ugh. And the x-ray was one that he kept for years for students to stump him. It didn't have any clavicles. And that's what he was, oh, you missed clavicles, you're so dumb. Yeah, I'm just like, what kind of rotation is this? My old 29-year-old self going, what have I got myself into? Anyways, but yeah, so don't get tunnel vision, look around everywhere, but you can say that all you want. Your first day on rotation, you're going to be scared. And it sucks. That new guy syndrome is the worst. Happens with any job you take. So, but yeah. Sternal end. So know what it makes. So we got the sternal end or the medial end of the clavicle. It's kind of interesting because it says sternal, but it attaches to the manubrium. Is that interesting? It should be called a manubrioclavicular joint. It's called a sternoclavicular. I find that fascinating. So I'm a nerd. I'm sorry. I'm going to go read about it later after class. I'll tell you guys about it. You guys interested? Just joking. All right. So your acromial end articulates with the scapula. There's a little piece called the acromion on the scapula. Kind of looks like a little tower. There's a little guy sitting up there, looking around, like in the parking lot for the mall, at Florida Mall. Those little towers that they have for security. So that makes the articulation there. So know which ends articulate where. So the sternal end or the medial end of the clavicle makes up the the acromial end makes up the acromioclavicular joint, yeah, or AC joint, SC joint. I'll accept those as well if you don't want to write everything out, like in a lab or something. Oh, look, he's got a nice green amulet today he's wearing. So what's this called? Looks like the USF bowl. Yeah, it's green. And then here's some more clavicles right here for you. The anatomizer machine. Here's your clavicle. Here's your scapula. Here's your humerus. So okay, so these two athletes are having bad days. They fell and hurt themselves. See that agony on his face. I can't really see what's going on here. He has a mask on, but yeah. So fallen outstretched hand, or foosh, F-O-O-S-H. Foosh is an actual term using the ER to kind of minimize the verbiage in saying fallen outstretched hand. You can just say 28-year-old football player sustained a foosh injury to the right upper extremity. Playing a pan at the right shoulder, obvious deformity, blah, blah, blah. So foosh, okay? So what does foosh stand for? Yes. Or if you want to say it in Latin, fum, fallen outstretched manus. Just kidding. All right, anyways. All right, so yeah, so as I mentioned, you got your brachial plexus, you got your subclavian artery, you got your first rib that can also create an issue with those puncture injuries, but it could lead to a lot of damage and injuries depending on the force. So this guy just is dealing with ground reaction force only and the force of possibly being pushed down. This guy has a huge gentleman alignment crushing him into the ground, so that's obviously more force combined with ground reaction force, and it meets right at there. So which one is a higher, more risk of neurovascular compromise in this type of thing? The top one or the bottom? Bottom one, yes. Okay. These are things you got to think about when I did, sports medicine is one of my caveats as well. So that's stuff we think about, the generation of force and mass and speed and all these things that go into injury. And eventually that's how I want you all to get. Scapula is the proper term. Shoulder blade is what the general population calls it. So I would like you guys to know which ribs overlie it. So you need to understand it's 2 through 7. You got your fossa is like a little shallow space. Supraspinous fossa, what muscle sits there? It's in the name, supraspinous. Yes, supraspinatus. Yes, supraspinous fossa, supraspinatus sits there. Infraspinous fossa, which is much more greater. What muscle? Just one of them. Infraspinatus. Perfect. And you got your teres major, minor, everything else. Okay. So their name it's pretty. I know you guys kind of probably put that in the back of your cellar in your brain back there, but kind of dig it back up again, okay? All right, know where things are. Chromium process is this bump right here, okay? Kind of you can feel it right here, okay? If you're interested, my left acromion is like super sharp and destroyed and deformed from numerous battles in the cage and ring. Mine are really sharp and elevated, but we'll do that in the lab or something. But yeah, so chromium process, you need to know where it is. It's superiorly palpable right here. There's 3 different types of shapes where some are domed, some are sharp, and some are flat. Okay, and that has a lot to do with certain types of injuries. But subscapular fossa, is that in the posterior part or in the anterior part? Don't look. Yes. Okay. And coracoid process is right here. It's literally right here, like next to that pectoral triangle right there. That's another site for attachment. So we have lots of scapulas downstairs. You guys can take a look at them, but you need to understand which side you're looking at. Okay, so do I see a spine here at all? No, right? So that would be the posterior part or anterior part? Perfect. So this whole section is called your subscapular fossa. And what muscle is there? Subscapularis, okay? All right, and this is your coracoid process right here. It's literally like right here. You can actually dig in deep enough, you can touch it, and your acromion is superior up here. Okay, that's more surface anatomy for you. Your spinous scapula is posteriorly. You see that, and then there's posterior part of your acromion. Your supraspinous fossa. What muscle goes there? Supraspinatus. Infraspinatus is here, and this is your ridge here. Okay. So if I were just to throw a scapula on the table and have you identify a bunch of stuff on it, you should be able to do that. Okay. All right, so this is a lateral view, or we call a scapular Y view on X-ray in the X-ray world. So we're looking at, if I were to rip the humerus right off, the humerus inserts right here, okay? This is like a profile view of it. So is this the posterior side or the anterior? What's back here, posterior or anterior? Posterior. Okay, so now you're at, so acromion is here, it's like a half moon. It's called a scapular Y because we're looking at the scapular and it's kind of shaped like a letter Y. You see that? This is going to let me know if the humerus is where it should be. Here's your glenoid fossa or glenoid cavity. It also has a glenoid labrum, which is a cartilage that acts like a suction cup to keep that humeral head in there. Okay, kind of things like that. So we have anatomy of the anatomy. So we just mentioned glenoid fossa. So supraglenoid tubercle. So that's basically, I mean, I'm not going to get too in depth on that. That's real like surgical stuff, but that's just where attachment sites for certain tendons. Okay, but that's more if you're going to go into like orthopedic surgery, you'll have to know that. But for now, all I'm concerned with, you were able to identify where the glenoid fossa is. Okay, is that fair for you guys? Just think at this level. Now you'll have an orthopedics class in the beginning of your spring semester, so we'll go over that as well. Okay. All right. So here's actual cadaveric scapula. Is this anterior or posterior view? Posterior view. Okay. Perfect. And here's your anatomage. It's got different colors. Okay. So why are we learning this? All right. So the shoulder joint or glenohumeral joint. So glenoid fossa, humerus, glenohumeral joint. That's what makes the shoulder joint. It's very mobile, okay? Don't smack your partners, but you can see how well it moves around, right? Very mobile, does a lot of things like this. And then so it's very prone to be knocked out of its socket, so to speak, okay? So any type of force. So you can see here that the humeral head is quite large compared to the glenoid fossa. Only like 1/4% of the humeral head is making contact with the glenoid fossa. Okay, so that glenoid labrum, that cartilage ring, is mainly what's keeping it in place. So that it acts like a suction cup, keeps it in there. So when there's a glenoid tear, glenoid labral tear, that we lose that suction and will lead to instability, and that's what leads to chronic shoulder dislocation and arthritis and all sorts of horrible things that can happen there. So, so if it's unstable, obviously it's going to come out. This is what it looks like normally when making contact. Anterior dislocations are most common, and it literally will get pushed anteriorly, and the muscles will contract and pull it down a little bit. And you'll see like a big divot formation here, like a big like crevice, because where your humerus is no longer there. So it'll be like much more lower and fit into this spot here. So another thing that can happen is a distraction force the axillary nerve could cause extra stretch on it. Those myelin sheaths get destroyed. When this is a posterior dislocation, so these are common in. Unfortunately, I've seen a lot of these with electrocutions, like workers who are standing in water and they do something and they really dislocate their shoulders posteriorly, or in seizures as well, most common. Okay, but less commonly seen in like a general ER, unless someone comes with a real bad grand mal seizure, posterior dislocation. So I ask you, what is more common, anterior or posterior shoulder dislocations? Anterior. Okay, perfect. Okay, and this is what they look like on radiographs. So here's your humeral head. Sorry. There it is, and then it should be lining up with this thing. This is your glenoid fossa right here. You see that? Okay. All right. So your articulations, we kind of went over these already. SC joint, EC joint. Your scapulothoracic joint is basically posteriorly. It's ribs 2 through 7, where the scapula, it doesn't really make any contact with the ribs itself, but when we're doing when we did those fun dance moves earlier with the techno music, it's basically your scapulothoracic joint we're doing, okay? All right. So, yeah, that is a joint. Then your glenohumeral joint. The anatomists call it the scapulohumeral joint, but we will call it the glenohumeral joint because we're going to be clinical, right? Not anatomists. Boring. Okay. All right, so here, let's take a 5-minute break. I'm losing you guys. Okay, 5 minutes, we'll come back. No? Yes? I just feel the energy's like, 5-minute break. Let's go. All right, here we go. All right, so sternoclavicular joint, also known as SC joint. It's even in the little thing I just found earlier. It articulates with the manubrium of your sternum, so it's interesting. And your first costa cartilage, your first rib, this little guy over here. Hold on, let me switch to this. Here, okay, here's your first rib, right? Here's your, what's this thing called? Manubrium. It's a USF bull right there, okay? How many of y'all went to USF? All right. I went to FSU. I don't like It's in the late 90s when we were actually good at football, so. Kind of. I know. So everyone find it, okay? So find your clavicle, go towards the medial side. The little bump right here you feel? That's your sternoclavicular joint, okay? All right. So it can dislocate and it will force anteriorly, creating this huge deformity. Back in the day, you just accepted the deformity, you're screwed. You kind of like, okay, here it is, everything's gonna scar down. Now they actually have cardiothoracic surgeons that actually go in there and manipulate and fix it. But it's a very delicate surgery because what's behind that manubrium? What huge structure? That's important. Heart, your aorta, aortic trunk, all those bad boys are back there. So is it worth the risk for you to have that bump put back in place? Probably for you guys. I mean, it's all about personal appearance. I mean, if you don't want to look like that, it's fine. But personally, I'd be like, what if you sneeze during surgery and you slip and cut your aorta in half? Yeah, it's a huge risk for it. That's all I'm saying. My thing, the risk outweighs the benefit. I would just walk around life with a big deformity, my SC joint, and tell fun stories. Yeah, I was saving a little kitten from a tree and I fell. But elevation, depression, protraction, retraction. So elevation, depression, retraction. Yes.
So when they do like cardiothoracic surgery, like how do they move the sternum? Like how do they move it?
They will either cauterize the ligaments and then let them scar down again. But sometimes they just go in with a bone saw and cut it open that way. Then they stitch it back to wires. They use the wires, they just wrap it around and that'll scar down eventually. Yeah, pretty interesting stuff. But yeah, but you're literally like looking at the aorta right there. Remember those 3 branches I had you guys? And you're just staring at them like the whole time, like oh my god, one little slip. It's like, so yeah, that's why I personally I'd be like, all right, I'm good. but yeah, so know these. It acts like a strut basically. Keeps your glenohumeral joint from rolling anteriorly. Okay, so it keeps yourself back. Without that, just pretend like. Let's pretend right now we ripped each other's clavicles off. Everyone do this motion. Grab here and go, sha. I want to hear it. Okay, good. Now throw them away. Throw them away. Now look what happens. Everyone do this. Okay, that's what a SC joint does. Okay, prevents that from happening. Okay, now you're all gonna remember that, right? Okay, so so it provides support. So this is a lot of minutia here. The different types of ligaments for the SC joint. What do you guys think? Yeah. All right. So I won't ask that of you this time, but just know where it is. Your manubrium, your first costal cartilage, all the movements involved, and it provides literally a support system, a strut, and commonly to either sublux, basically just rolls over that that lateral clavicular end rolls over the anterior part of the manubrium. And, but that's more pathophys. Just I want you to know what it helps with. Okay, action. So if I were to ask you what makes up the SC joint, you're going to say perfect. Just right here. Okay, awesome. All right. Yeah, this is lots of minutia here. Like, unless you're going to go into that type of thing, don't worry about it. So acromioclavicular joint, AC joint. So this one I'm going to have you understand the ligaments because it's a very common injury. It allows for a slight gliding moment there. So your clavicle literally attaches to the acromion by these ligaments right here. And those ligaments can become overstretched and sprained with a fallen out stretched hand, or if you land directly on your shoulder. We call that an AC joint sprain or AC joint separation. There are 6 different classes of that, each varying in degree of height of separation. We'll go over that in orthopedics, but just know that it's very prone to injury. I've injured my left AC joint multiple times, so I have a lot of scar tissue and deformity here. But basically these ligaments combine to create like a small capsule here, okay? This is your AC joint. Here's your clavicle and your acromion, so it makes the acromioclavicular joint right there. It's a little space there. When you're in orthopedics, you'll have to find that AC joint superiorly with the person's shirt off, so you can do an AC joint injection of cortisone if they have a lot of arthritis and pain in there. So you have to be very, very careful and astute as to know where that articulation is. But I need you to understand what ligaments make up the AC joint. So you got your coracoclavicular ligament, which is this guy right here. So you have your coracoid process. Everyone's in agreement? And here's your clavicle. So this ligament is your coracoclavicular ligament, okay? And then this one, you got your acromion, you got your clavicle, and you got a ligament here. So what's that ligament called? Yeah, coracoclavicular ligament, okay? So this, what does it allow you to do? It allows you to raise your hand above your head when you have a question. So when someone has an AC joint separation, are they going to be able to ask a question or no? Not really, right? They have to go like, pick me. I swear, I know the answer. Sir, relax. Security, get him out. All right, so know that. So this is what I mentioned. So sometimes this can happen. The clavicle will go up superiorly. Your acromion will stay where it's at. It literally rips the ligaments right off or over. It's like grade 1 and 2. It's kind of like an overstretch. Grade 3 is a little tear. Grade 4, literally it gets pulled down. And grade 5 is, we call it high 5. So it's literally like way up here. And grade 6 is like even higher. We call it tenting, where the skin is like tenting because the clavicle is about to break through the skin. That's a term we use when I'm describing this type of injury. There's tenting, possibly grade 6 AC joint separation. I've seen that in one of the guys that I used to train with MMA. He was in a pro fight and he injured his, and I was his cornerman, and it was literally like out here. He kept fighting. He won. It was crazy. And then we had to get surgery. We had to get wires and literally bring it down. He never was the same ever since. So it kind of behooves if he had stopped fighting, could he have continued, for a further career? Those last 2 rounds he wanted to finish out. The mentality of that is something else we talk about. But those 2 rounds are worth your entire career. I don't know, but yeah. So literally, he's got wires now keeping that clavicle down. So, but yeah, as I mentioned, so scapulothoracic, I mentioned you don't really have any bones touching each other. And these are the muscles that basically surround that area. We went over these already in the last block, but just know that it's really just gliding over each other. The muscles around the scapula that retract and protract your scapula are the ones that are going to create this muscle, this joint to move, but there's really no rubbing of that together. Okay, so glenohumeral joint, glenoid fossa is that dark, shallow cavity in there. Literally, just this little part of the humeral head articulates with it. Your rotator cuff muscles, you've got 4 rotator cuff muscles. You got 3 of the 4 attaching at the glenoid, greater tuberosity, or greater tuberosity, and 1 attaching at the lesser tuberosity. The one that attaches at the lesser tuberosity is your subscapularis. Write that down because that's an important difference maker there, because you can get confused. Okay, so those, imagine you got like four tentacles, and here's your humeral head, and this is what's happening. And then you got the suction cup of the glenoid labrum. So that's what's keeping your shoulder joint in place. Okay, so you have a weak or a arthritic joint, or your tendons are have adipose tissue inside them, which happens with disuse, or you have a weak rotator cuff. What's going to happen is, like, here's your glenoid fossa right here, my right hand, here's your humerus. It's going to basically start to lower, okay? Basically go down inferiorly. So you'll see a huge gap on X-ray between the glenoid, the humeral head and the acromion. Okay, so those 4 muscles will keep it in place. The most weakest part is down here inferiorly, because it's literally like there's not much there to keep it. All the muscles are superior lateral to keep it in place. So anything that's weaker, it's not going to allow it to basically, have much reinforcement down there inferiorly, so it's going to come out of it easier. So, so these are all your motions here. Everyone knows how to do these or no? Okay, so forward flexion, FF, is this, of your shoulder, okay? Shoulder forward flexion. Every time you say a joint motion, you have to say the actual name of the joint, articulation. So shoulder flexion. Don't just say flexion. I mean, flexion of what? Shoulder flexion, shoulder extension. You're reaching for the baton like you're on the track and field team, okay? Abduction, midline, median, going away from it. Adduction, I'm adding to the midline. Medial or internal rotation, going in towards the medial and away, external rotation. And circumduction is basically, doing this motion. Okay? Y'all remember that? Okay. All right, so glenohumeral joints. So you got 3 of them. They basically are very specific to orthopedic surgery. They're kind of thickenings in this joint capsule here. Just know that there are ligaments for the glenohumeral joint. I'm not going to get specific on these, okay? Yes?
Could you just repeat what you said on the last slide about what attaches to the greater tuberosity?
Oh, so you have 4 rotator cuff muscles. We'll learn that in a second, but there's supraspinatus, infraspinatus, teres major, and subscapularis. I said that right. No, supraspinatus. Sorry, supraspinatus, infraspinatus, teres major, and subscapularis. Sits muscles. That's what it's called. SITS. So the subscapularis is the only one that attaches to the lesser. The other 3 attach to the greater. Okay, so they're all responsible for everything else. Okay, but yeah. So I just want you to know that glenohumeral joint has ligaments, and that's all. Okay, I'm not gonna. This is too much minutia for you right now at this moment to understand ligamentous structure right now. You guys want to learn about, be tested on this or no? I don't know. I just think this is more geared toward orthopedic class in the spring semester. Too much minutia there. Okay, so this is a model with these. It's like this. This is a good one. Glenohumeral ligament. That's all I want you to know. See, it's right there. This is anterior, posterior. Anterior, correct. Yeah, chlorococlavicular ligament. So this is a good one to understand. All right, there's several structures here that are important. So you have bursa. So bursa is little fluid-filled sacs. They're filled with synovial fluid. They're there for a purpose, to allow for simple gliding motion of these joints, kind of like a lubricant, like ball bearings in your tires and everything like that, if you guys know about mechanics. But it's there for create a nice, smooth gliding environment. They're also there for protection against impact. You have them everywhere throughout your body. Okay, just in this particular region, we have one in the subacromial region. So that one's already intimate to the undersurface of the acromion. It attaches there as fluid-filled sac. Now, with lots of friction or overuse activity, let's say like I'm a youngin and I'm all about weightlifting, like I just want to lift weights 5 times a day, every day, no matter what. I'm overtraining. What's going to happen? My subacromial bursa is going to get inflamed. It's going to get bigger and bigger and bigger. And what's going to happen to that subacromial space? Can get cramped in there, right? So you're not be able to move as well. So that's going to cause pain, leading to a condition called subacromial bursitis, which is horribly painful and limiting, and it can affect your work life and miss a lot of work from days from work and stuff like that. So understand that they're there for protection, fluid motion, but if you do overuse activity or get injured there, they're going to get inflamed and swollen and create joint compromise. Joint motion compromise is a proper terminology. Subdeltoid bursa, so that's going to separate your deltoid muscle from the head of the humerus. It's literally like if you were like to follow your from superiorly up here down, your deltoid, and literally at where the deltoid ends of that little curvature, you can actually feel this little hook there. That's where your subdeltoid bursa is, okay? There's a deltoid tubercle there as well. And that's where this deltoid bursa is. So that's also there for protection. So if you were to get bumped into, that can also swell up and cause pain. So that allows that deltoid motion, the shoulder abduction, to be done smoothly. If it's inflamed, it's going to be a lot painful and everything else. Subcoracoid bursa. Okay, so that one's literally tucked away in here. It's anterior to the tendon of the subscapularis. So that's going to allow for fluid motion of internal rotation. Subscapularis does internal rotation, so fluid motions there. So if anyone's got any issues with those motions and they're complaining of like I've been doing pull-ups for months and or something that's like literally when you do this, everyone do this, like hands up, okay, you're decreasing your subacromial space, okay? Imagine there's like this much, when you put your humeral head, it decreases by that much, okay? So if you do that a lot, like overhead activity, like pitchers, volleyball players, mechanics, artistes, painters, all that stuff, you're going to create a lot of tension and friction in there, so you get inflamed and angry. So think about that as well, okay? So their main purpose is to, limit friction and allow for fluid joint motion. But when those get angry, that gets compromised. Okay, so if I were to ask you, what's the largest upper extremity bone? What are you gonna say? Perfect. All right. So it creates the glenohumeral joint superiorly. Distally, it articulates your radius and ulna, creating what we call the elbow joint. You all familiar with the elbow joint? That's good. Awesome. We're halfway there then. All right. So remember we discussed the epiphysis, metaphysis, right here's a little curved part. This is the entire part here called diaphysis or shaft. Deltoid tuberosity, you see this little protuberance right here? That's where I was literally palpating earlier. That's where deltoid bursa is, and that's where the deltoid muscle inserts. Imagine it contracts and literally hooks onto that deltoid tuberosity and lifts your shoulder up. That's one of the motions of deltoid. The deltoid muscle does abduction. How many of you do workouts at the gym? You do this exercise, work your shoulders. That's what happens. The deltoid's contracting and it's pulling on that deltoid tuberosity to lift your arm up. Okay. So when you guys ask me, do we know origin insertions? Think of it like that. If you understand the origin, the insertion, you're going to be able to understand the action a lot better. Because think of it as like, one part of it is stabilized, like staged, like anchored in, and the other side is literally like someone pulling it up or letting it go. Okay, if you think of it that way, for this entire block, which is challenging, you'll be able to understand origin, insertions, actions a lot easier than just singly trying to memorize origin, insertion. If you think about what's actually happening, like combine everything, it's going to be a lot easier for you guys. And that's my advice to you guys for this next block, because it's going to be a beast with this stuff, okay? And just don't take that lightly. Take what I just said and use it, okay? Everyone understood? Everyone understand that? Okay, all right. So distally, this can get very, very challenging here at the distal humerus, because look, it looks all like strange and like, oh my God, it looks so stressful. So, but yeah, so the capitulum is this portion right here. It looks like a little croissant rolled up, in the microwave. If you're gonna microwave a croissant, it doesn't come out like it should look. So that's what it looks like. So your microwave croissant looks like a capitulum, all right? So trochlea. So know which ones articulate with who. So your trochlea is right there. He is medial to your capitulum. He's like a little part right here. So there's a little notch there right in here. So know which part of the distal humerus articulates with the next set of bones, okay? So if I ask you what articulates with the radial head, what are you going to say? Capitulum. And with the ulna, trochlea. So this is very important, okay? Because elbow is very, very confusing, specifically an elbow x-ray, and even more specifically, pediatric elbow and pediatric elbow x-ray. Those are like, you need like a whole semester to understand that stuff, okay? But this is very challenging, so I would love for you guys to understand this and know this. There are portions distally called epicondyles. So this whole thing is called your condyle. But these little protuberances, we call them epi, meaning on top of the condyle. Those are sites for tendon and ligament attachments, okay? So medial epicondyle, lateral epicondyle. They're literally for your medial collateral ligaments, lateral collateral ligaments of your elbow to kind of keep that elbow joint in place. So yeah, you have to understand these things, what they're there for. So know which the proximal aspect, which is up here in this portion. So there is the head of the humerus, as we discussed, that's going to articulate with the glenoid fossa, creating the glenohumeral joint. The anatomic neck is basically this part here. It's going to separate the head of the humerus from the tubercles, or I call them tuberosities clinically. So greater tuberosity is most lateral, lesser is most medial, and creates a bicipital groove. Think of it, y'all know what the Grand Canyon is? Think of it like that. So you got a greater side, one side of the canyon is much greater, much lateral, and then got a lesser side, and in the middle is like a little ravine. And within that ravine is the long head of the biceps tendon. We'll go over that later, but it's literally right here. You can actually like find your long head of the biceps tendon. You rub really hard into your anterior shoulder. It's a little like, feels like a cable right here. If y'all feel that, like look at your anterior shoulder, right? X-ray rotate like this, and it'll be much better to feel. Feel it like a cable, like a rope. Yeah, that's your long head of the biceps tendon. So that's your bicipital groove. Lateral to that is your greater tuberosity. Medial to that is your lesser tuberosity. Okay. So greater tuberosity I just mentioned earlier. So it's attachment site for your supraspinatus, infraspinatus, and teres minor. Okay. I will never use the term intertubercular sulcus. Never. I will always call it bicipital groove. Okay, so scratch the anatomic term there. So bicipital groove. So like I mentioned, it's like a canyon, it's like a little ravine along here. The biceps tendon runs through there. It's literally this whole thing right here. Bicipital groove is this. Follow the red dot as it falls through here. That's your bicipital groove. Okay. This is your lesser tuberosity right here. Greater tuberosity over here. Humeral head. Anatomic neck is literally between here. Your surgical neck is this part, your diaphysis right there. They call it surgical neck. Why? That's where most of the surgeries occur. When you have a proximal humerus fracture, this is where most of the time occurs right there. Now we can either fix those with intramedullary rod or a plate, or we just get rid of it and do a reverse total shoulder arthroplasty, where we just cut the whole thing off and give them an implant there. We'll go over that later. So, all right. So notice this is anterior and posterior. I'll get familiar because I could throw, let's say in lab, we'll just throw a humerus on the table and be like, "What's this? You can't touch it. You can't move around. You're gonna panic. It's a humerus." But which side? I actually worked with a surgeon. He was a hip surgeon. Guess what his name was? Dr. Hugh Morris. I'm serious. He's a hip surgeon. Hugh Morris. I was just like, when I first met him, I'm like, serious, right? You're joking, right? He's like, no, I'm Dr. Hugh Morris. He was very serious. I had like this big, I don't know if you guys seen Magnum PI. He had this big, broad mustache. Very serious guy, really. But I'm Dr. Hugh Morris. But it was just funny. In orthopedics, you're Dr. Hugh Morris.
He got mad at you for calling Dr. Hugh.
Oh, yeah, he'd get really pissed. He'd kick you out of the OR. Get out of my OR! I'm like, okay. You want a snack room? Bye. I got kicked out of the OR once. Yeah. Well, he was yelling at me. I didn't appreciate it much, so I told him what's up, and I got asked to leave. So I stepped back, pulled my scrub out, and went to the lounge and had some snacks. There's these sandwiches that are triangular. I don't know if you guys seen them. They're not really good, but that's all I had. It's chicken salad sandwich. But yeah. Stand up to for yourselves. I mean, don't ever let someone I know it's hard when you first get there, but after a year or two, I'm like, I'm not taking your crap. I'm like, no, man, don't talk to me like that. Get out of my OR. I'm like, okay. Had lunch early. But that was my only time. I was told not to do that again, so anyways, fun stories. All right, so as I mentioned, epicondyles are little bony protuberances on top of the condyle, basically. So you have medial and lateral side. You have all these structures that I mentioned. So know the articulations. It's better worded on the last slide, but coronoid fossa. So coronoid fossa. So this little can you see that or no? Yeah, it's literally. God, can you? I can't see it. Can you turn it on? Sorry. So you can't see. Thank you. Round of applause. Okay, there it is. So you all see this? So it says coronoid process right here. So this bone here is your ulna, and there's a little skateboard ramp right here. See that? There's a little guy skateboarding there. Okay, so here is where your trochlea right here meets your coronoid process right here. Your capitulum on the other side right here meets your radius, as we learned earlier, but this is your coronoid process right here. So this can get fractured in elbow dislocations. We have a superior part, middle part, and lower part, grade 1, 2, and 3. But that whole area there is called your coronoid fossa right here. There's a little shallow. We have these in the lab. I really want you to take a good look at them. There's a little shallow portion. If I were to turn this out toward you, you'll be able to see it. But there's your coronoid process right here. Here and here is your coronoid fossa. So it allows that trochlea to fit right in there. So know that as I just mentioned, so trochlea articulates with the ulna at the coronoid process. That's what I'm trying to say to you guys, okay? Capitulum articulates with the radial head. You can see how the elbow can be very confusing, right? It's very intricate structure, commonly injured, so I really would like to stress that you guys understand this, because I will test you on this. Why? Because it's important, right? You won't see stuff like this, okay? Elbow anatomy is very challenging, and I don't want you guys to just gloss over this. And when you get out there, you don't know what you're looking at, okay? All right, so here's a more condensed view of the humerus. You can actually see the structure a lot better. So this entire thing is your lesser tubercle. Greater tubercle is over here. That's your bicipital groove. Does that make better sense in that one when you see it this way? So now you can actually your deltoid tuberosity. So your deltoid literally covers this whole area. See that? That big round muscle we have here. There's three sides of it. There's anterior, middle, and posterior deltoid. They all go into that triangular delta shape. Remember delta, deltoid tubercle pulls up, abduction. Okay. So, and then distally, we have your capitulum, which is your croissant after the microwave. And you have your trochlea, which is like a, I don't know if you want to make something up, go ahead. But then we have this, remember how I mentioned the structures that are closer to the midline are much larger? Remember that? Medial epicondyle, we'll see how large it is. And lateral condyle, see the size comparison, okay? All right. So this is for a site for muscle, tendon, ligament attachment. But literally, like down here, this is the most confusing part for PA students in their first semester. Like literally, everyone gets the elbow confused. I don't want you guys to be in that group anymore. Okay. All right. Sounds like a plan. I have faith in you. All right.
I have a question.
Yes.
For the greater and lesser tubercle, is the lesser tubercle is it smaller or is it more medial?
It's more medial. Yeah. It's just you can call it the medial. Like if an anatomist were to call it, you'd probably call it the medial tubercle. But clinically, we call it the lesser tuberosity. So I think it's because it has less muscle and tendon attachments compared to the greater one. So that's the way to think of it too. So. Yeah, greater is lateral, lesser is medial. Is a question. Okay, so all right, so here's the crux of everything here. Okay, so here's your distal humerus. And we're looking at the medial side here because they're pointing to the medial epicondyle, which is quite larger compared to lateral condyle. You got your trochlea here. This whole portion here is called trochlea. Everyone's following me? Okay. This is the head of the radius right here. And here's the neck of the radius, this part. So radial neck, radial head. Now this is very important for coding. If you are not able to identify a radial neck versus radial head fracture and you put the wrong code in, you just cost the company money or yourself money, or because there's different ways of managing. One pays more than the other. Radial head pays more. Radial neck does not pay much. Radial head is possibly surgical. See how it works? You have to know your stuff. Yeah, you can be a great PA and pass your pants, but if you're not producing, they keep track of that, okay? It's just the honest truth right now. I wish someone had told me that when I was here. Now I'm telling you guys that, okay? It's not all, rainbows and lollipops out there. It's death, dismemberment, and darkness sometimes. Okay? Yes. It's more probably the right arm because you're medial. So.
The medial side is like on the outer. It looks like it's on the outer. That's why I think it's on the
Well, it's facing. The medial side is right here. Sorry. See that? So we're looking at it medially. So I'm trying like the camera's literally pointing right here. It's a right arm, basically. Yeah. Yes. Imagine that camera's literally right there. So, but yeah. Sorry if I crushed you guys' journey. But I don't know. I just when I got out there, it was like I got punched in the mouth by real world, and I'm like, oh boy. This is not what they said it would be like. Anyways. But radius, ulna, coronoid process, your little skateboard ramp here. Okay. This is your coronoid fossa is literally right here. Semi-lunar notch. I mean, it looks like a luna, like a moon. That's why I call it semi-lunar. But literally, this is a right elbow medial sided. That would answer your question. Okay. All right. So here's some more study material. Okay. And some more study material. And some more study material. Radius. The radius. The radio. Radio. This one actually moves over your ulna. Okay, we'll show you in a second. All right, so the head of the radius, as I just mentioned, articulates with your capitulum. So neck of the radius, so that's basically the diaphyseal portion of the radius, if you remember that part. Proximal end is towards the distal humerus, distal end is towards the wrist, okay? So know that. So there's a right, I always call it the long head of the biceps tendon distally, the distal biceps tendon, distal biceps tendon inserts right at that radial tuberosity, okay? That part can rupture, leading to a biceps tendon rupture, and literally that muscle will kind of ride proximally and end up here and creating a big gap here. We call that the Popeye muscle. You know who Popeye is? He eats spinach. He's a badass. You know, beats everyone up. So he has like these muscles that are like kind of awkwardly shaped, but distal biceps tendon. When you press in that distal radius region, that radial tuberosity, and there's a big gap there, and then you got this huge muscle like riding up here, and the person can't literally flex their arm anymore. That's a biceps tendon rupture. So think about it. You got your biceps here, and you got that tendon, distal tendon inserting right that radial tuberosity. If it flexes and contracts, what's happening? It's pulling that up. You see that? Let's try that again. You're going to put your left hand on your right bicep and contract and visualize that distal tendon pulling on that radial tuberosity to bring your forearm up. So if I were to ask you what is the insertion of the biceps, radial tuberosity. Okay, see how that works? Literally, like do this, move around for this block. This is the way you're gonna understand stuff. Okay, all right. So as we travel distally towards the wrist, you're gonna see that the radius is gonna get much more wider and larger to basically counteract the motions of the wrist. We have certain parts called styloid processes. We have a radial styloid process and an ulnar styloid process. They're named for their distal portions of the radius and ulnar. So if we were to go back into anatomical position, there's a little bump right here you can feel. That's your radial styloid. And that little bump out here on your ulnar, and when you touch it, that's your ulnar styloid process, okay? And your ulnar styloid right here, you all feel a little bump? And the bump on the radial side is right here. It's a radial styloid process, okay? So know what's in red. So basically, if I were to fall on an outstretched hand, most of the force is going to be propagated towards the radial side, radial styloid process. So it's an attachment site for several forearm muscles. We'll get into that when we get to the forearm muscle section. But yeah, it's basically the radial styloid part. So you have your scaphoid and lunate. Those are two of the 8 carpal bones I want you to know, okay? They create the scapholunate ligament. Sorry, the scapholunate joint, which is joined by a scapholunate ligament. And there's a little shallow groove inside of the distal portion of the radial styloid portion where these guys fit in perfectly like puzzle pieces, okay? Called scaphoid fossa and lunate fossa, okay? The scapholunate ligament is very, very important. That one was going to keep your carpal bone stable and your wrist stable. That ligament tears, it's the beginning and the end for your wrist, okay? I'm telling you that from experience, okay? All right, and we'll go in a second. Okay, so. All right, so here's your radius and ulna separated. So no, is this the distal or proximal end right here? Proximal. And what's this portion here called? Radial head, perfect. What's this? And what's this? Radial tuberosity. Okay, perfect. And what inserts there? Biceps tendon, yeah. Distal biceps tendon, okay. And then we have the radial notch is basically where the radial head fits right into that and part of the proximal ulna. Here's your trochlear notch, so that big croissant fits right in there. Your coronoid process, that's the BMX ramp, and your ulnar tuberosity right here. So I'll get familiar with the anatomy of this, so literally know this slide very well. It's important because these are where muscle tendons and everything inserts to. Okay, so this is so Carl is not in anatomic position, as we all know. So this is called your radius. So you can see here that when this happens, when we do this rotation type thing, the radius is literally moving over the ulna. Okay, it's called a radio button, or to realize when it's on top, like this, like when we're in anatomic position, superiorly, when we're like this, you can like do your thumb like an antenna, like a radio antenna. That way you know the radius is superior and the ulna is inferior when you're in this anatomic position. Okay, so radius is superior. Okay, your radio antenna. All right, so it's going to rotate, so that radial head is already going to do like one of these motions here, and we'll show you there. So this is just going to rotate on that elbow joint and create motion there. This one in green is your scaphoid. These are all your metacarpals in blue. All right, so the ulna, that's the one that's inferior. Okay, right here, if you're in anatomical position, it's right there. It's basically one fracture we call a mid-shaft ulna fracture. It's called a nightstick fracture, named for, it's an eponym commonly due to riots where the police strike you with a nightstick, and defensively we do this and our ulna breaks. That's why it's called a nightstick fracture. I don't know if that term's still used because of the times we live in now, but everybody called a middle third ulnar fracture, right? So, but yeah, so basically it's going to be, if you're here, anatomic position, it's going to be much closer to the midline, so it's medial compared to the radius, okay? See that? If I'm in anatomic position, it's medial to that. So the proximal end, as we have just discussed, articulates with the trochlea. You got your coronoid process. Your olecranon process is basically this bony protuberance in the posterior part of your ulna. If I do this, touch it. Mine's very sharp from striking people all my life, and there you go. But yeah, got two of them. These can fracture easily as well from people falling like this. Triceps tendon attaches there. Triceps tendon get very large amount of force. They contract, pull superiorly while you fall on the concrete and literally pull the bone and fracture. It's a huge surgery. It ruins your joint motion for the rest of your life. But yeah, we do our best in there. So we kind of discussed all this stuff in red already. You know, it's a trochlear notch, articulates with the humerus. Radial notch, that's a space for the radial head. The ulna does the opposite, okay, of the radius. The radius expands and gets wider distally at the wrist, but proximally it gets wider. It starts off wider and gets much more narrow distally, okay? So it's the opposite of the radius. So radius enlarges much more distally, more surface area. Ulna proximally has much more surface area and decreases in size distally as it gets to the wrist, okay? Now if you're in lab, you can compare the two right there and you're able to see that perfectly, okay? Or just look back at here. As you can see, the ulna, this is proximal up here. The ulna is much larger and it gets much more narrow here. the radius distally is larger compared to proximally. It's much less large. I guess. It's not as big as it was in there. Okay, so, but yeah, so interesting note here. So distally here, we mentioned here that the lunate and scaphoid bones have little notches there to fit right in. The ulna does not articulate with any of the carpal bones. Okay, there's a little space there, but it's filled with a disc called the triangular fibrocartilage complex, TFCC. We'll go over that later, but it's a little like disc that kind of creates a space saver, I guess, or something to put in between those two ones. But the ulna does not articulate with the carpal bones. Okay. Does the ulna articulate with the carpal bones distally? Okay, perfect. All right. And here's your ulna, as we mentioned. Another study material there. So, fallen outstretched hand is a common mechanism of injury. When I worked trauma, I reduced probably 15 to 20 a night. I reduced a bunch of distal radius fractures. People fell all the time, especially in Chicago. They slip on the snow, and they don't realize that. And reflexively, we do this. That's why it was funny when I had like teenagers like come see me with their mama. Like, oh, I have a boxer's fracture. I broke my fifth metacarpal. I fell. I'm like, oh, how'd you fall? Like this. I fell like this on the ground. Reflexively, we open our hand and extend our wrist. That's how we fall. I'm like, interesting. But then, we delve more into it, you get more history. I get asked to leave by the mom. Okay, Mr. Perez, yes, would you mind excuse me? No problem. I leave the room, close the door. I hear the mom yelling at the kid, are you fighting again? I just waited, started dictating my note. And then she opened the door, okay, you can come back in now. And the kid's like this, like, I'm sorry I lied. Yeah, I got in a fight. Yeah, it was just funny, but yeah, don't believe a teenager with this. He fell like this. Fell with a closed fist. Reflexively, you always fall like that, and the distal radius breaks. You never should break your fifth metacarpal falling like that, but you don't ever fall with a closed fist on the ground, okay? And if you do, let me know. I'd like to do a research project on it. So. But yeah, as we get older, our bones become more brittle, so it's most common. A lot of 80-year-old females with osteoporosis. Osteoporosis affects their wrist. They were always like fall and break their wrist, and we'd reduce it, put in a splint. Sometimes they needed surgery, so we'd admit them if it was real bad. But yeah, so is that? Do you guys? Okay, hold on. Clinical significance. This is something you'll see in ER class, so I'm not going to get into it. I mean, this is an anatomy course, not a pathophys course, but just these are names of specific distal radius fractures. You'll see the difference that you'll know, but don't worry about, the eponyms for this. Colles fracture is an anatomy course, not an orthopedics course, so this is what the Colles fracture looks like. We get dorsal displacement of the distal fragment. This is your distal fragment. It goes dorsally, which is this way. And it looks like this, like a dinner fork. But that's just the clinical significance of why we're learning this. So know which nerves, muscocutaneous, radial, and ulnar, supply the elbow joint. I'm sure you already know it's a synovial type hinge joint as it opens and closes like a door. This stuff already went over. The trochanter and capitulum know which bones they articulate with the forearm and its actions at the elbow joint. So flexion is decreasing the joint angle. So flexion, extension. Now pronation is your basically, so I think I taught you there was supination. You're creating a bowl of soup. You taste the soup, you don't like it, you're bleh, pronation. So you throw it away, okay? So supination, you make a bowl of soup, you don't like it, you throw it away, pronation, okay? Sounds good? All right, so that's what happens at the elbow joint. Know which nerves supply it. So actions, we already know what they articulate with. Collateral ligaments of the elbow joint. So um, anybody knows what Tommy John surgery is? Any baseball enthusiasts? So basically, it was the name of the patient, I believe, the pitcher long ago in the professionals, and had an ulnar collateral ligament tear. And they did this experimental procedure. They called it Tommy John surgery. Oh God, don't tell me someone else is breaking. Okay. um, so basically they repaired it and he's able to extend his pitching career, but yeah, ulnar collateral ligament is on the medial side here. It basically provides medial stabilization of the elbow joint. Radial collateral ligament is on the lateral part of your elbow joint, and that's where it's located. So the annular ligament is literally wraps around the humeral, sorry, the radial head. Now it's like a ring, and it literally basically like here's your radial, it literally wraps around like a ring. Now in children, the bone has yet to develop fully, so that ring, there's a space between that ring and the bone. So everyone's heard of the nursemaid's elbow when they pull the kids up.
Mm-hmm.
If you got a kid from the army, you pull them up in the air and it dislocates. That's why that happens. The radial head is not mature enough yet, so it literally slides out of that annular ligament. And they always come in like this. They're not very happy. That's when you take your white coat off, you go in and you try to, have experience. So you just go, hey, how's it going? Who's this little guy? Who's this little Billy, the teddy bear? Okay, and you just distract him with that, and you kindly do some uh, supination, flexion, and then obviously it'll pop right in, and he'll be laughing and playing within seconds. Okay, like nothing happened. So it's just basically education to the parents: don't pull your kids up by their hands. Okay, that's bad. Okay. That's the importance of the annular ligament. But know which side collateral ligaments of the elbow joint are located. So radial collateral ligament and ulnar collateral ligament. Which side is the ulnar collateral ligament on? Medial. And radial lateral. Okay. Same thing when we discuss the hand. We don't use lateral medial in the hand. It's always going to be ulnar or radial. Okay. So get into the habit of that with upper extremity. Okay. This pain is located radial to the midline of the volar aspect of his right hand, something like that. Okay. All right. So next, so here's some more study material for you guys. And significance of this. So all our forearm muscles, dorsally, they do extension, wrist extension. Okay. So everyone, put your hands dorsally on your forearm and do wrist extension. You feel how they're contracting? So all your muscles on the dorsal side do wrist extension, and they originate from the lateral epicondyle of your distal humerus, okay? All the wrist extensors, lateral epicondyle. Now it's the opposite. Let's go volar side. Put your hands on your volar side, your forearm. Now do wrist flexion. You feel the muscles working there? So all the anterior or volar side muscles of your forearm do wrist flexion. And they originate from your medial epicondyle. Okay, don't forget that. That's very important. Okay, so if you got someone that it hurts when I do wrist extension, it's most likely the source of pain is going to be the origin. Okay, that distal portion of your humerus, your lateral epicondyle. We call that tennis elbow or lateral epicondylitis. It's due to excessive wrist extension. It's very painful, and you don't have to know on your test. It's just I want you to orient yourself on the wrist motions and actions. So right now I covered all those dastardly forearm muscles that we have to learn. And the ones that are located on the extensor side, that's your dorsal side. Flexor side is your volar side, okay? For flexors, okay? So no difference in those two. So which sides is doing this, wrist extension. Dorsal, which is also known as your wrist extensor side, okay? This is your volar side, doing wrist flexion, okay? Originating from your medial epicondyle. So your flexors of your form originate from your medial epicondyle, flexors of your form, medial epicondyle, flexors of your, sorry, excuse me, I misspoke. They call them forearm flexors, but the form doesn't move. It's actually the wrist. So wrist flexors originate from your medial epicondyle. Wrist extensors originate from your lateral epicondyle. Okay? So that should help you when we get more in depth into the forearm muscle. Okay? All right. So this is an olecranon bursitis. This is an angry bursa right here. You can see what they look like. I've seen some that are like literally like this big. This one, they can be chronic or acute. Chronic meaning if you got someone that's on their phone all day at the office, resting their elbow on the table over time, it's going to get angry and inflamed. Same thing, the example I gave you guys when I worked at Camp Lejeune with the Marines, that they would be in the foxhole all night on their knee, pointing their gun out. They'd get prepatellar bursitis. Same thing with administrative assistant on the phone or resting their elbows on there, it will get inflamed. This can be also due to a fall or an impact, or you hit something, it gets inflamed and angry. This allows for that triceps tendon to glide smoothly over the bony prominence called the olecranon process, okay? But just know that I'm just worried about your subcutaneous olecranon bursa, okay? Don't worry about the other little guys. That's too much minutia there, okay? Because clinically, this is the one that's important. Someone bangs their elbow, you come in with that, okay, synovial fluid increases when there's inflammation, when there's injury, it just swells up. We can treat this many ways. I make multiple puncture wounds with my needle because I just do one puncture wound to put cortisone in there or exsanguinate it or draw the fluid out. It's going to eventually open back up sooner or later. You put multiple holes, there's no way for it would just kind of be like those, what are those things called? When you make spaghetti and pour the water out. Yeah, it's a strainer. Yeah, colander, yeah, that's what they're so I made a colander out of the bursa, so that way it all kind of dissipated and it wouldn't fill back up again, okay? So, but yeah, sorry, I'm not a culinary expert, so. All right, so your proximal radial ulnar joint, okay, that's right here. So as I mentioned, here's your annular ligament. It's wrapped tightly around the radial neck. You can see the motion that it does here. So literally like moves within that region there. So the annular ligament is like a little like covering for it just rotate in, and that's what allows the motion to occur. So it allows it to rotate safely, so it won't dislocate or disarticulate or tear anything in there. But yeah, it's basically what it does. Is your proximal radial ulnar joint, your radius, your ulna, and your ligament, and creates a rotation motion. Okay, that's what that happens there in a nutshell. Distal radial ulnar joint, or the DRUJ, as we write it in the real world, DRUJ, drudge. So it's you don't have to know it's a pivot type of synovial joint. Don't worry about that. It's basically distally right here at this juncture right here. So basically it's just very intimate to each other. It's got spaces for it to fit, like a little fossa, like a little perfect puzzle piece there. That's basically all you need to know about the distal radial ulnar joint. There's like research articles on this stuff. Distal radial ulnar joint, it's very, very taxing, demanding. It's this part here, okay? You see that? That's your distal radial ulnar joint. That can dislocate, that can sublux, that can literally, if you have a strong enough force, your lunate bone will literally rip right through here, and this is your interosseous membrane, just a bunch of fascia where all the nerves and stuff lay in. That can literally tear right through it, called a drudge joint separation or widening. But just know that it articulates distally. There's a little space for it called the ulnar notch. Just know that it's there. I'm not going to get too intricate with it because this is a real complex topic in the world of orthopedics. So, hand and surface anatomy. So, how much time we have? It's 3 minutes. Okay, so let's stop here. We'll continue later. Yes? No, just know that it's there. Well. Okay, so when we talk about the wrist, in Latin terms, it is pronounced carpus. Okay, so if you see the term carpus, it stands for wrist, and carpus being delineated into 8 small bones called carpal bones. Okay, there's 8 of them. There are 2 rows. There's a proximal row and a distal row. At this point in the lecture and this point in the course, you should know what proximal and distal are. So be able to know which bones of the carpus are found in your proximal row and which ones are found in your distal row, okay? I'm not going to have you name each ligamentous name for each of the carpal bones. There are far too many. There's some on the dorsal side, some on the volar side. That's more for your orthopedic class. I just want you to understand the names of each carpal bone and what particular row they are in, proximal or distal. They basically will give your wrist support and stability that it needs to do everyday minute fine motor control functions and stability. If there's any compromise with any of those ligaments within the carpus, you're going to have lots of decreased wrist strength, grip strength, loss of fine motor control, immense pain, audible clicking and popping, sudden onset of post-traumatic arthritis because of the instabilities and we rub against each bone, and that's very painful. So if you ever were to tear one of your wrist or carpus ligaments, it's a big deal. It's going to basically be the beginning of something that's going to affect you. And in this profession, PA profession, you will need both your hands, okay, whatever you do. If there's any compromise in that, you're going to be limited in what you can do and what they're going to let you do. Specifically in Florida, there's a lot of litigious situations here, okay? So I'm telling you from experience, okay? So, but yeah, so understand the shape of them as well, and which ones articulate with what, okay? Remember I mentioned, I think in anatomy lab, that at the distal portion of the radius, there is fossa there. There's a lunate fossa and a scaphoid fossa. Now, which bones articulate with that? Scaphoid and fossa. Yeah, scaphoid and lunate. Perfect, yeah. So that's another way to remember it. So would those 2 bones be in the proximal or the distal row? Proximal. Okay, good. So you got 2 that are found in proximal already. So think of it that way. This diagram basically shows all of them there. There's a volar side and a dorsal side. So be able to differentiate which ones are which if the carpus is either shown to you anteriorly or dorsally, okay? So don't just study one side of the hand, all right? Okay, so one way to identify these is to go from, it says here, lateral to medial. Just scratch that. I'd rather use the correct anatomical terminology that we use in orthopedics. So anatomical division, okay, right? We're here. So what they mean by lateral is radial, okay? So radial to ulnar, that's the terminology we use. So if you want to put lateral meaning radial, medial meaning ulnar, the correct way to describe a hand injury or location to a specialist is, the patient presents with pain on the radial aspect of his right carpus extending to the ulnar aspect. See what I'm saying? So you're usually using lateral to medial, but the correct terminology is radial and ulnar, okay? That makes sense to you guys?
Mm-hmm.
That's just, I'm trying to guide you guys correctly, okay? So I'll make note to change that for next year. So scaphoid, lunate, triquetrum, and pisiform. Those are your bones. Okay, you all seen your snuff box already? right? Guess who lives there? Scaphoid, okay? He's right there. Okay, back in the day, put a little snuff there and did their thing. So, but yeah, so these are the bones in your proximal row. Okay, so if I ask you, what are the bones of the proximal row? Are you going to say tracheoid, trim, and pisiform? So there's in orthopedics we call it scaphoid, not scaphoid. I want y'all to understand lingo so you look cool when you get out there. You're like, who's this person talking about? No, so scaphoid, lunate. Luna is moon in Spanish. It actually does look like a little bit of a luna, moon. Triquetrum, thumb. It's closest to the thumb. Okay, that's another way to remember it. Pisiform. It's like a little guy over there on the ulnar side. Okay, he gets broken sometimes when people fall after his hand, but most commonly, the most common bone of the wrist of the carpus that's fractured in a fall after his hand is your scaphoid. Okay, scaphoid's like a little wafer. You seen those wafer desserts before? Like kind of like a creamy center and the two thin wick. That's kind of like how the scaphoid is. That's why it's difficult to find a fracture on initial x-rays when someone falls on Asher's hand because the bone is not really, it's more porous than any other bones. So it takes about a couple weeks for fracture healing to show up on an x-ray. That's why you do serial x-rays. Like, we'll get you, your pain on the snuff box, you fell on your hand. Let's put you in a splint, come back in 2 weeks, wait for a splint to go down. We'll take our x-ray, and then you'll see that dreaded black line through there, okay? Depending, I mean, if it's obvious one that's completely broken in half down the waist of the scaphoid, that's the most commonly fractured part. Remember, in the clavicle, the middle third is the most fractured part of the clavicle. The waist, as we call it in scaphoid, is the most commonly fractured. Actually, like if you take a wafer and break it down the center, that's your scaphoid, okay? So you guys know that. All right, so know your carpal bones and what row they're in. Distal row. So this is from radial to ulnar as well. Your trapezium, trapezoid, capitate, and hamate. The hamate has a little hook on there. It's called hook of the hamate. That also can get fractured too. So there's plenty of mnemonics out there on the internet. You can pick one up if you'd like. Some are appropriate, some not so appropriate. Or you can just make one up on your own, okay? These are challenging to know. I was speaking to a few of you in the lab the other day. There's lots of bony models down there. Literally manipulating them and actually visualizing them and understanding what they actually do look like is going to be your best bet at understanding this stuff, okay? I mean, how many of you guys, notice a difference by actually manipulating an actual radius and ulna in your hands and understanding, oh my God, this is what it's doing. Yeah, see, that's what I need you guys to do. Specifically with the wrist bones, this is commonly mistaken part of the human anatomy, the wrist bones. No one understands them, no one knows what they do. Once they become like compromised, they can rotate volarly and dorsally, creating what we call a visi and disi. That's something for orthopedics. But that's a very painful condition and leads to compromise, people losing their jobs and unemployment rates, all that other stuff. So the hands are very important, particularly if there's a thumb injury. That's an emergency. We take that high priority. No one wants to lose their thumb, right? Pinkies, we just kind of, or small fingers, it's like, oh, we'll get to that later. They can declare themselves. So, but thumb is a medical emergency. We get microvascular involved because there's tiny vessels there. But yeah, so once again, radial to ulnar. So there's some color-coded things for you here. This is the anatomage, and some more color coding here as well. Okay, this is more study material for you. So, all right, so kind of touched a little bit on all this already. So the only issue that we have here is, and I've used this example before. So there's a bridge called MacArthur Causeway that's connecting the mainland Miami to Miami Beach. Let's say that bridge gets obliterated. Okay. Now, no one can get supplies to Miami Beach. Miami Beach falls to imminent doom. Okay? Same thing here. So if you got your scaphoid bone and it breaks down the center, there's a special branch off the radial artery that feeds the proximal part of the scaphoid. So if that bone breaks, that vessel breaks, so that proximal portion of the scaphoid is not getting blood anymore and becomes necrotic and dies. So that's why it's an important thing to be able to differentiate between your wrist bones and know which one's broken. Because when mass tearing is at their snuff box, you need to understand that, okay, how bad is this thing? If we wait too long, that proximal part of the scaphoid is going to become necrotic and die, okay? Because the blood flow to that part has been compromised. You understand that? So the bridge is out, as Schwarzenegger says. The bridge is out, there's no blood flow coming, so it ends up dying. So it ends up in a condition called avascular necrosis. So basically it produces a whole bunch, that's the start of everything. So it ends up looking like awful on an x-ray, you'll see. Lunate dislocation, those are also bad. Scapholunate ligament gets ruptured, and it leads to basically a dislocation. That can also break and lead to compromised blood flow to the bone, leading to avascular necrosis. Do you all know what avascular necrosis is? So it's in the term, avascular. So something's not getting blood. Necrotic means death. So the bone is not getting blood, so it dies. And you can't have a dead bone in your wrist because it's going to lead to lots of problems and issues. So we have to do a procedure called a Kingbach procedure. That's later down the road, but having a dead or dying bone anywhere in your body is never good. Okay, it happens in the femoral neck as well. Yeah, they agree as well. So, so yeah, hamate fractures. So these are, you usually have to get like a CT scan on these to find these. So basically, you just press down on basically the volar part of their hand or their hamate region. That's usually where the fracture is located. It can be due to chronic stress, like seeing golfers or powerful swings. It can also be from a fall, but very difficult to assess by X-rays. But physical exam findings, pressing down your bones, comparing the other side, looking for obvious signs, and getting a great history will determine this thing. Okay, so you have to find these out. So the next few slides, anyone want to guess whose X-rays these are?
Yours.
How do you know? It says my name on it. Yeah, I should have. It's okay. It's me, so there's no hip violation. It is me. All right, so got a big red circle here. So which bone is this? Let me get my little pointer thing here. What bone is this guy right here? Scaphoid, okay. And what's this little guy right here? Lunate. This is your capitate right here. Okay, so does this look normal, this little gap here? That's bad. That's a grade 4 scapholunate ligament rupture. Grade 4 is as bad as they get, and that happened to me. That was the beginning of the end of my surgical career. Now I'm here. It's not bad. It's just it's a very dark time for me back then. So this one here is an MRI arthrogram. Okay, so they laid me down like this, and they put a IV in me, basically, so I forgot the name of it. And they put some dye in there, and the dye went and located the pathology, and it settled in there. And you can see the difference in when increased volume, increased pressure, so it separated the bones even further to corroborate the grade 4 rupture. You can see the difference here. That's a big gap there. See that? Compared to the one on X-ray. Everyone see that? Pretty devastating. So the capitate bone right here, he literally acted like a little piercing thing and blasted through here. The radius also, it's forced this way, blasted through here. I don't know, it was called acute on chronic, meaning I probably heard it a few years earlier, and then my continued work in trauma and orthopedics, like It's a very hard labor, laborious job. Probably made it work. Probably healed a scar tissue, and then the scar tissue tore at this point. So that's what it looks like. There's an oblique view here. So you can see by me showing you this, you probably have a better idea of what the bones are now, right?
Mhm.
And I'm just sharing this to share with you. I don't have to share with you, but I'm okay with it. Okay, you guys okay with it?
Yes,
All right.
thank you.
Don't be like, oh, well, be all like, ew, he showed us his X-rays. Huh, what's that?
So, if you think that you had a previous injury to this area and it's spilled over, do you feel any pain?
Yeah. So we have a question here by Laura at the front. So she asked me if I had felt anything like symptom-wise. What was it called, acute or chronic? Yes. There was years of. I was a competitive kickboxer and MMA fighter, and I fought for 35, 36 years. And my last event, I had wrist pain for 2 years. That was like, whatever, I'm fine. Doing push-ups killed me. Doing bench press killed me. And then towards fall 2019, I started seeing the effects in the operating room. I was losing my grip strength suturing. My sutures weren't as tight. I had to get help doing them, and that was becoming a problem for everybody, see? So I had to see the hand surgeon, and he was like, why don't you see me in the hallway? I was like, I don't want a hallway consult. I want to be seen by you in the office to see what the hell's going on, and that's what they found. And so that was the end of it. But yeah, I had wrist pain on the dorsal part right here. That was really bad. I heard audible clicking and popping, grinding. Grip strength was going away. I was just like, whatever, I'll be fine. It'll go away. But and in the fall of every year is the busiest time for surgery. Why is that? Everyone meets their deductible towards November, December, so you want to get their surgeries done. So it puts a lot of strain on the OR staff. We stay late, we get there earlier, so I think that's what did me in. I was just like busy, like hammering implants in. So, but yeah, it was. Oh yeah, I don't mind sharing. It sucked. It was really painful. And yeah, so that was me. That was beginning of my demise. And here we go here. So they did a few surgeries. They had some fun with this 4 times. And here's what it looks like. So I don't have the first one on here. So the first one they took my extensor carpi radialis brevis tendon, which is right here. I have a big scar here. You all have to know what that muscle is, right? It's called ECRB, extensor carpi radialis brevis. That's one of your forearm muscles, as you did know. So they took that one out, took the muscle off of it, used the tendon as a graft to bring it across the bones here, like from one side to the other. But they also put a metallic suture around that tendon and they put 3 drill holes and put some bone screws in there. They're actually screws, like metal screws you see like at IKEA, but they're made out of bone. They're not made out of metal, and they actually grow into the bone that you already have, and that's how it heals. So that's how you don't see the screws there. But apparently this started happening again. Even after the first surgery, it started opening up again. Doesn't that suck? Yeah. And then they put a pin in you. Let's put a pin and see if that works. Then it started having an effect called windshield wipering effect. You know what that is? It starts happening to the pin inside your wrist. That was probably the worst pain I ever experienced. Because the cast, he didn't cut a window in. He just let the cast, so the pin is sticking out in my skin. And every time I move, it rub the cast on the pin and send vibrations through my wrist bone. Yeah, like as my partner, she was like, you were in such agony. Like, it was miserable. Like, I was just in my sling. I'd move a certain way. I was it was just miserable. So, I mean, yeah, you can actually see how it progressed from up here down to like even further down. See how it should have been like in the middle of the capitate. Now it's more proximally. See how it just became compromised. So, yeah, so then I needed another surgery. Number 3, where is it? That's not it. Oh, it's just some more. That one. Anybody see anything missing?
you missing?
They took my entire proximal row out. Yeah, that was surgery number 3. Let's take out his proximal carpal row. That's the problem. We just create a new ligament. So they shoved the capitate bone, which is right here. You guys following along? I'm not boring you guys, right? Okay, so the capitate bone right here. Scapholunate triquetrum are gone. So they're gone. Bye-bye. So the capitate is now shoved into the lunate fossa. The issue is the lunate fossa is designed for the lunate bone, correct? But now we're taking the capitate, which is not fit in the lunate fossa, we're just shoving it in there, doing what we can, okay? That makes sense to you guys? Yeah, so they put a bunch of cadaver graft as cushioning and support around here. 2 weeks later, I developed a high fever. Developed a high fever, redness, pus started coming out of my incision, and I almost lost my arm. So I had a reaction to the cadaver graft. Redness, streaking, high fever. I remember I called out, I'm like, something's not right, man. Oh no, you should just give us some time. I'm like, screw you. I went to the ER my damn self. I said, and the good thing is that you know people at the ER like Javier. I'm like, yeah, I need this something right. You know, so they had to wash my wrist out, take everything out. Yeah, they were about to do an above elbow amputation on me because it got so bad. So sorry, it's hard for me to talk about this, but I like sharing it so you guys understand how when people at work would tell me, "Why aren't you back yet? It's just a wrist." That really stung. So don't ever use that term. Oh, it's just a wrist. What's wrong? You can't work. I'm like, you have no idea what I went through. I lost my freaking arm over this ligament just being torn. So yeah, so that's been a few more months in a cast. Again, 3 months in a cast. I IV, damn PICC line in my neck, 6 months of that crap, and having a nurse come to my house and chew me antibiotics. So I was on disability, you know. So yeah, so this is what it looks like, and then things just went worse. I developed post-traumatic arthritis, the infection, everything just destroyed my joints. So I ended up having to get this is an oblique view of it here, a wrist diffusion. So this is what I have in my wrist right now. Titanium plate. This is a lateral view of my wrist. 8 screws. This chunk of bone here is my pelvis. My entire left pelvis is missing here, and they shoved it in my wrist. So I have a nasty scar right here on my left lower abdomen, okay? Took a big chunk of it and shoved it in there because I told them, like, don't you dare give me a cadaver graft. And I had to bring another surgeon in that I knew. I said, I want him in there because he knows how to do that. You don't. Oh, it'll be fine. It was just a mine. I'm like, I need to lost my freaking arm, dude. I want my own body part in my wrist. So yeah, I had him just take it's called an autograft. Auto mean you. Allograft is from a cadaver. So the first one I had an allograft. It was just soft tissue from had a huge reaction, lost my arm, and then the autograft was from me. They shoved it in there, and because basically there was a big gap between my wrist and without the cadaver tissue in there, it was just a big. My hand, I think, was doing this completely. I had no wrist, so I had a second opinion by a doctor in New York Hospital for Special Surgery. They are the premier orthopedic research hospital in the world. Named Doctor. I'm not gonna say the name of the doctor, but he takes care of the New York Philharmonic's fingers and wrists and hands. So you can tell this guy knows what the hell he's doing. And he also took care of like the New York Knicks and all the. They even had like a pretty prestigious. Yeah. So we went over everything because I wanted to get a total wrist arthroplasty because those he developed one. That particular doctor developed one for young people like myself that were very active. And I was a very active person. But he said I didn't qualify because he's like, I don't trust you. You've been martial artists for almost 40 years, and now you want a freaking total wrist. You can mess that up. No, you need a wrist fusion. So I get a wrist fusion, so they put a titanium plate on my dorsal of my wrist. They positioned it at 20 degrees of wrist extension, so I can at least have some sort of function. Because if it was flat like this, I won't be able to do anything. I'd be like, just be doing this. Oh, great, everything sucks. But now it's now I have a 20 degrees of wrist extension, so it's literally stuck like this. We call it my Lego hand at home. So that's what it looks like. I'm literally stuck like this. So. Yeah, it's a little Lego hand. But since the tendon length stayed the same in the thumb and I lost all those bones, it's stuck like this now. So pretty much, like if I give you a thumbs up, it'd be like, there you go, that's all I got. So, yes.
I have a question.
Yeah.
When they decided to take like all the carpal bones out, like why? Or did they consult you before?
Yeah, they did. Yeah, that was like the third surgery. So since the repair failed twice, the reconstruction failed, and they did the fixation, the wrist joint developed post-traumatic arthritis, which was really, really painful. So they were like, the wrist is that particular wrist joint is shot. We have to just get rid of it and make you a new joint with your distal row. But to put like padding in all the spaces where the bones were missing, we would put some cadaver tissue in there. And then my body was like, ooh, I don't like this. And I had like 105 fever. I didn't feel good. Red streaking down my arm. I was like, he was like, oh, don't worry. I'm like, I said, screw you, man. I'm going to the hospital. I just took myself. Not feeling good. But yeah, so that's why they're like, okay, the joint's shot. We're gonna have to just make a new joint out of the next row of carpal bone. So, but yeah, yes.
So the arthroplasty would have been like implants.
Yeah, so they would have done like a ball and socket implant, and that would have allowed me to have some wrist motion. But he didn't trust me because I was so active. I was an active person. I've been always active since I was little. Martial arts, like weightlifting. I was like, everyone knew me as like, you don't stop. So. That he didn't trust me, so he didn't want to do that to me because it would have failed again. There've been 5 surgeries that failed, so they decided to fixate it with a titanium plate. That's what it looks like. That's what I have on my wrist right now. So 8 screws. There's about $800 per screw. Yeah, very expensive, and the plate's like $3,500. So yeah, and then the implant guy gets a good percentage of that. So all he does is stay in the room and drops it into the sterile field. Yes.
How does that like ligament tear like compare like the carpal tunnel like
Carpal tunnel. So the transverse ligament is in the carpal tunnel. That's mostly just to kind of keep that median nerve in place. What happens is that ligament gets so tight and tight and tight from you like doing so much wrist extension, so they have to release that, and that will relieve all the tension. And all that adipose tissue in there will just kind of cushion the nerve and protect it. Whereas in the scapholunate ligament, that's very important. That's like the main one that keeps your wrist in check. If that one tears, everything just falls apart. So it's a very important ligament. So any pain along the proximal carpal row and radial or distal radial ulnar joint, DRUJ, always get X-rays and see that separation there. Okay. Right. You're welcome. So yeah, so this is what I look like now. And I'll show you some photos of, this is me after one of them. I can't remember anymore, but these are some of the surgeries that they had. So they had to go back in there. Here's where my ECRV was taken out of right here. They put one of the pins in through here and then sort of, I guess, shoved the implant in, or the other one, or did all the work there. So, this is like my hand afterwards. So. Everyone okay? No one's nauseous or feels weird now because I've told this. You guys. No one's okay?
Yeah.
I don't be honest. I don't want to hear anything later. He's whatever. I can't even think of anything right now. So. Yeah, so this is after one of them. I got a big hematoma stuck right here. That sucked. And here it is right here. Loculated blood right there. So you can see a lot of my wrist. Look at that. Look how swollen my thumb is. Yeah, no more knuckles. They're all like hiding under swelling, and this is what I deal with now. So notice the immense amount of atrophy. The thumb is stuck like that. You can see the tendons. Yeah, I lost a lot of muscle here. Yeah, the wrist will not. I've lost wrist flexion, extension, radial ulnar deviation. All I have is supination and pronation now. So literally, I lost everything. It's very difficult to do things now. I'm still adapting to life with it, but at least I can now make a fist, and my strength is like probably 60% of what it used to be. It took 6 years for it to get like this. So it wasn't until recently I was able. Like January this year, I was able to finally make a fist. So, but yeah. So yeah, I'm not meaning to weird you guys out. I just wanted to share my experience with you guys so you have a better understanding of the carpal bones, kind of know how hard they are. How y'all feel much better now about the carpal bones after I shared this with you? Everybody? Okay. Yeah. So sorry if I got emotional. It really sucked. It was a hard time in my life. So all right, so we're gonna move up the food chain now to metacarpals. Okay, meta means middle. So we have 1, 2, 3, 4, 5 metacarpals. Like they count on Sesame Street. Yeah, so, and we go from which side? From radial or ulnar we start? Radial, okay, cool. So what hand is this? Left hand. Yes, left hand. So, all right, so metacarpal head is the name of the anatomy. So these are metacarpal heads. Those are most distally found. Proximally, they're called bases. So base is here. Proximally, it articulates with the distal carpal row. Okay, so the base of the metacarpals, 2, 3, 4, 5, approximate to the distal carpal row. And then we got your metatarsal heads here. And they make something called the metacarpal phalangeal joint or MCP joint. So if you see anything in this area, these are your knuckles, okay? And these are the ones you punch with, okay? So I don't recommend it. Just walk away, run. First metacarpal is over here with the number 1 by it. Okay, it is obviously the thickest and the shortest one compared to these other ones. See that? See the difference? So this is a metacarpal, this is a proximal phalanx and distal phalanx. So the thumb only has 2 phalanges. The rest of your lesser digits, as we call them, or lesser phalanges, you got a proximal phalanx, middle phalanx, and distal phalanx. You see that? And in between, we got your metacarpal phalangeal joint, or MCP joint, proximal interphalangeal joint, or PIP joint right here, and then your distal interphalangeal joint, DIP joint. So MCP, PIP, DIP. The thumb does not have a middle phalanx. It's just proximal and distal, and then we call this one interphalangeal joint of the left, or right thumb, whatever it is, left thumb. Okay, that makes sense to you guys. This is going to help you understand where everything is. So the thumb does not have. Which one does the thumb not have? Middle. Perfect. All right. How many metacarpals are there? And here are your guys here. Okay. All right. I can't see. All right, so yeah, this has a bunch of colors on it. This is one of our study material for you guys. Does you guys see this okay? All right. So literally get down in the lab and literally play with that little floppy wrist bone. How many got to use it in the lab the other day? The hand model? Okay, yeah, use that one. It literally, you can get a good understanding of it. So this is some more color-coded stuff from the anatomy for you guys to study from. So this is stuff I already went over. Each digit has 3 phalanges except the thumb. So base, shaft, head distally. So the distal parts of your phalanx, the phalanges here, those are called tufts, T-U-F-T-S, okay? There are a condition called tuft fractures. They do happen. Pretty much you're self-limiting. You just kind of put a buddy tape on them and they'll heal in like 6 weeks. But the tuft of the portion of your phalanges is in the distal phalanx, not the proximal. Okay, so that's a good way to understand it. But here is we saw this already in like the first lecture we had as a cohort here. But they say here's your tuft here right under your fingernail. So it's a common fracture. Pretty much you don't do much for it. You just splint it. Here's another hand model here. Carpals, metacarpals, phalanges. You'll have to look at what view you're looking at here, dorsal versus volar. I will do y'all a solid and identify that for you guys in the exam. Okay, I'm not going to be, because you're also understanding of my personal story here. So you weren't like, oh God, this guy talks too much about himself. All right, gold, I think, right? Is that gold? Okay, so know these. I'd study the anatomology images always. They always seem to pop up on your exams, right?
Yes.
You guys are like, damn it. Should have messed around with the machine more down at the lab. All right, so MCP joints. These are your knuckles, okay? These are the ones you punch objects with, or people, or you do knuckle push-ups with, or stuff like that. So they do flexion and extension. So you all put your hand like this and do this like the bye-bye waving. This is flexion at your MCP joint, and this is extension, okay? Flexion, extension, flexion, extension. These are hand exercises I had to do for like 6 years. So. Everybody's tired already? Yeah, isn't it? That's how your intrinsic hand muscles working, okay? So abduction, hands like this, like you're saying, hey man, how's it going? So abduction. This is all occurring at the knuckle joints, okay? Abduction, adduction, abduction, adduction. Everybody got that? MCP joints still doing a thing. And circumduction. Remember you guys watch Family Guy? There's that little like monkey that hides in the closet and points at people. Yeah, it looks pretty scary, but yeah, circumduction. That's what it does as well as the MCP joint. So know all your motions of your MCP joint. It's kind of like you're pointing at someone, you right there. Okay? All right. So when I say collateral ligaments, what do I mean by that? Are they on top, on the bottom, or the side? On the sides, right? Okay. So collateral means they're just basically on the side. When you say cruciate ligaments, they're actually crossing like the letter X, okay? Collateral is like this. Stabilizing, cruciate is like this, the letter X, okay? Or like this, right? So there's also, much more fine-tuning ligaments that can get sprained. These deep transverse metacarpal ligaments, those are the ones that when people complain of pain here, oh my God, it hurts, they sprain one of those little tiny ligaments, and they do hurt a lot. So we just kind of like do that. So MCP joint is your knuckles. So everyone make a fist. What are we looking at right here? The knuckles? Now I'm going to teach you something right now. How to punch. Yes, basically. So we have your hand. Notice that you got your first metacarpal right here, your thumb. You got your second metacarpal head, which is your MCP joint. Try and move it. It doesn't move that well, right?
No.
How about the third metacarpal head? A little bit, but not so much. Try the fourth one now. Move it. Very floppy.
Yeah.
Now the fifth one, very floppy.
Yeah.
So, well, you guys, I'm not promoting violence. I'm just saying. If self-defense, yes, self-defense. Right? Everyone's okay. Self-defense class right now. So you always want to strike with the second and third. Those are your more stable ones, okay? And the force is lining up right with your radius bone, so you have more strength. Now, everyone's heard the term boxer's fracture before? It's actually a misnomer because a boxer that wouldn't happen to them if they do know how to punch, right? I'd say the wannabe boxer's fracture because they usually will throw a wild haymaker and hit with the fourth and fifth ones, which are not very stable, right? So that's why the fracture occurs on the middle third of the fifth metacarpal in a boxer's fracture, okay? Yes?
For anatomy purposes, how do you do a correct fist, like when you're punching?
Oh,
For anatomy purposes, that's crazy.
so line up your pads here, your fingertips, against your metacarpal heads here. See that right here, very tight. Then you bend, then you flex, and then you put your thumb directly over that, and then you squeeze the last little bit of your fourth and fifth MCP joints to make these guys jut out a little more. Okay, see that? Mine are pretty sharp and hypertrophied from all the striking I've done since I was 6 years old. But so imagine y'all. This will be cool right now. Everybody has a little cup with you guys right now, right? You have like a cup or a mug with you. Okay, so yeah. So don't use the handle. Use the side, like the. Don't grab it by the handle. So everyone grab your cup or what do you call it now? Stanley, yeah, that thing, tumbler, whatever. All right, so everyone grab it normally, like that. Notice that without your fourth and fifth metacarpal joints being so mobile, you won't be able to grip anything. Okay, now put it down. Now just grab it like this, like just kind of just stick your hand in there. See? You can't do it, right? So if the fourth and fifth MCP joints were just like the second and third, try it like that without them moving. Can you grab it? No. So kind of
Like barely. It's like
you're you're using your thenar eminence and your thumb to basically keep it like that. So. But if you do this, you got grip strength. Okay. All right. So. Oh yeah, sorry. All right. So all right, let's all settle down. All right. So y'all understand the MCP joints better now?
Yes.
Okay. I like to be practical. So yeah, if someone's in like has a boxer's fracture, they put in an ulnar gutter splint, so it'll be like this. So their ability to hold their Stanley Cup is going to be compromised. Okay, especially if they have like a left wrist fusion, they can't. They're already screwed. So yeah, makes life difficult. But yeah, so I would know what that does, and what we just went over. Not the fighting stuff. Just FYI. I just gave you an example to help you guys retain this better. Yes, for the lab quiz. I'm gonna bring the little guy from the gym downstairs that we saw in the video. Why don't you guys punch him? I watch your form. You're like, all right, you pass. Yes.
Yep, it's time.
All right. I know.
You just let us know what's on this test and we'll be
All right, cool.
golden.
All right, so the next row up, your interphalangeal joints. Okay, I kind of went over this briefly, but your PIP joints. So if y'all can do this with your right index finger, just stabilize at the MCP joint and do this.
Yeah, I can't keep the top straight. Yeah, yours is like, very, oh my god, this is really hard.
Yeah, so that's basically your PIP joint, okay? He does flexion and extension. Or if you're about to like climb something. All right. And then your DIP joint is like this one. I don't know if you can try that. Can anyone do that? Like flex their DIP joint like that?
Only the top.
All right. So this is from me, guys. This is from me doing as a kid. My sensei had me do fingertip push-ups. He'd take us outside on this hot sidewalk. I grew up in Miami, and we had to do fingertip push-ups on the hot sidewalk and knuckles. So you can't do it now; you get a big lawsuit. But back then, in the '80s, it was okay to do that to children. But yeah, so flexion extension at the PIP joint is much greater when compared to the DIP joint. You can't do it as much. Okay, see that? DIP joint is most distal one, but PIP joint I can do a little more. It's kind of like your like mace finger. Someone's coming at you, go hit them with mace, or bear spray, whatever. Right? All right, so everyone's okay. Flexion extension. If you're gonna grip something, like you're climbing something, those are your PIP and DIP joints. Okay. All right, so. Okay. So palmar view, volar view, anterior view all mean the same thing, okay? So I'm going to write that down. So this is more schematic of everything. So we have down here another joint we're just going to learn right now. So this is your carpal metacarpal joint. You got your metacarpal here. Everyone see my little red circle? Metacarpal, and then we have your carpal, okay? That creates a carpal metacarpal joint. This is where a term called basilar joint or saddle joint arthritis occurs, which is very, very painful. We just remove this bone and fill it in with a tendon and create like this little chewing gum type of wad and shove it in there and create the space. So that's a thumb arthroplasty that we do for that. Okay, so this is what my hand looked like on the lateral x-ray view, as you saw. So the thumb is basically staring right at you. So the trapezium or trapeze thumb, if you want to remember it that way, it's closest to the thumb, right? That creates a carpal metacarpal. So I've asked you what bones make up the CMC joint. What are you going to say? Trapezium and the first metacarpal. Okay. Okay. All right. Don't get confused because I see this every. I've only been here a year and 11 months, but when I used to teach orthopedics as adjunct professor here, people always think this was the first metacarpal, the index finger. So don't get confused. I think it's, we're always like pointing at people. This is number 2. This is number, okay? It's like number 1. Yeah, thumbs up. Okay, there you go. All right. Oh my God, look who it is again. Brachial plexus. All right. So everything we just discussed emanates from your brachial plexus, the C5 through T1, and these are names of peripheral nerves: radial, ulnar, median, and musculocutaneous nerve. I wouldn't know where those are located on an anatomical diagram. Just letting you know. Just for the hell of it, no reason. Just to talk. So, radial, ulnar, median, and musculocutaneous nerve distribution. Where they affect, what dermatome, all that stuff. And we got your arteries. So I saw a few of you mess around with that arm model. So did it have blood vessels on there? I can't remember. The arteries, not the veins. No veins. Okay. So we'll just know the arteries. Subclavian, we know where that one is. How important is that one? Axillary artery, brachial arteries, very important. Radial and ulnar. Okay. So where do you take your pulse at? If you squeeze both radial and ulnar at the same time, what happens? You start feeling like strange. So, but yeah. On the digital Allen test, we'll go over that later. So here's the anatomage again. So you might want to know where these are. I think I left part of it there. This is Carl again. I can tell by his hands. His hands, he's never in an anatomical position. He doesn't like to cooperate. So venous drainage. Just know that they're basically right next to each other. Let's take a 6.5 minute break. And we'll come back. Ready? Okay, I think it's okay. So we're on. All right. So anyone understand what UE means? All right, cool. I'm gonna have that on the test. So. We have muscles. Anybody know who Arnold Schwarzenegger is? He's got lots of muscles. All right, so pectoralis major. We went over this one, right? Yeah. So he's back again. So I need you to understand his origin, insertion, and innervation. Remember, innervation got a few people because I might put 2 of the 4 choices could be and then there's a little comma afterwards with the innervation, and you're all like, I could sense you guys like cursing me out in the middle of the test, like, why does he do that? 2 answers, 1 choice. So understand that. Y'all know what I'm talking about, right? Yeah. Getting evil eyes from you always. Not used to that. Okay, so pectoralis major. What I mean by flexus the humerus, remember F for forward flexion. So your shoulder is flexing the humerus forward. Okay, so forward flexion, adduction. So we call it horizontal adduction. So put your arm like this, and go adduction, this is what the main motion of your pectoralis major is, okay? Horizontal adduction, okay? External rotates the humerus if you do this or this, and draws the scapula anterior and inferior. So basically it rounds out your back and depresses it, okay? But main ones is basically adduction of the arm. Horizontal adduction is what I'll be concerned with, and forward flexion. So basically it's the motion of doing a push-up or a bench press with dumbbells or barbell, okay? And obviously know where it's located. Is it here? Is that your pectoralis major?
No.
How about over here? Yes. Okay. Good. All right. This model has it indicated for you, major and minor. Look how much minor compared to the major is. It's very puny. Okay. Y'all got that? All right. It's like a big hole in his chest. I think this is one image in your last exam. So that's where it's located on Carl there. Pectoralis minor, we just saw what it was. So use that one we just saw earlier. You actually see that was a good model picture of it, because it literally comes out of the third to fifth ribs as you saw in there. And your coracoid process. Y'all know where that is now, coracoid process? You guys got an idea of that in the lab? If you have there's a bunch of scapula bones by themselves there. I'm being honest with you guys. Literally grab these things and stare at them and look at them, film them, three-dimensional, know which one you're looking at, right versus left. Try to guess which muscles go where. If not, this one's going to be a little challenge for you guys, okay? Because there's a lot of stuff, right? Okay, so just heed my warning. Okay, so know the medial pectoral nerve, and what does it do? It's basically mostly a synergistic muscle for your prime movers, such as your pec major, and also aids with the muscles of inspiration. So if you just know that part, you'll be fine. But know what it looks like, know where it's located, and here it is again, okay? So count your lower ribs, and here's your coracoid process right here. So if you visualize it and see where it's coming from, when I say origin, think of the word anchor. An anchor. Anchor is stabilizing, right? It's fixed to the ground, right? Or when you're in a little ship on a cruise and it drops the anchor and it stabilizes the cruise ship, okay? So think of something like that. The insertion is the one that's going to be like causing it to move. So everyone like, I was doing this in the lab the other day, but everyone put your arm out like this. Okay, now flex your elbow, put your hand on your bicep. You feel your bicep contracting, right? So the distal bicep tendon inserts here at the radial tuberosity. You can kind of feel it. So when it contracts, imagine it literally pulling your forearm up, okay? Y'all do that right now? That's what's happening, okay? If you understand the action first, then work your way back. Okay, if it's doing this, what is being pulled on? That's your insertion. And what's the base? What is like this, the anchor that's allowing this motion to happen? That's your origin, okay? Does that make sense? Think of it that way, and you won't have to individually memorize each thing, okay? If you think of it as a whole group, as a dynamic motion, you'll be able to understand it better, okay? That's why I recommend how you study for this test. Okay, so here's some more pictures of Carl. Serratus anterior, so outer surface or most lateral surface of your ribs 1 through 8. So costal aspect of the medial margin of the scapula, so basically back in there. This is going to, when I say protraction, abduct. What is abduct? It's going away from the midline. So when we do this, what are we doing here? Everyone do this? Remember this from scapular exercises we did? That's your serratus anterior, okay? It's basically pulling your scapulas away from your spine. That's called protraction or abduction, okay? Serratus anterior is doing this, okay? All right, so that should help you guys. And how is it doing that? Because it's basically coming from the insertion, the medial margin of the scapula, which is facing your spine, medial part. So actually that's where it's pulling down. You see how it's making sense now? Okay, yeah. All right. Okay. And here's where it's located, right here. Kind of gives you a shredded effect here. And here's where it's located on the anatomage, okay? So you can see it's attached to those ribs, originates from those ribs. That's your anchor. The insertion is the medial part of your scapula. So if it's pulling it, it's basically allowing that to open up, okay? That makes sense? All right, so deltoid muscle, means you got an anterior, medial, and posterior head of the deltoid. He attaches at your inserts at your deltoid tubercle. So when he contracts, he's pulling your arm in this position, which is called shoulder abduction, okay? You all do this in the gym at all? Like arm raises, as they call them? Yes. All right. So axillary nerve is the innervation origin. Anterolateral third of the clavicle, your acromion, spinous scapula. So any one of those is fair game, okay? So I could just choose any one of those and you'll have to know it, okay? Action. So I'm just gonna have you worry about abduction, okay? I'm not gonna worry about clavicular part. Just know that it does shoulder abduction, okay? I'm not gonna get too minutiae with that. All right, so there it is. It's your big shoulder muscle. This is the one we have, and I saw a bunch of you like walking around the lab with it in your hand. You guys took it off, yes?
Sorry, should we understand like what part of the deltoid muscle abducts it, or just know the deltoid muscle abducts the arm?
Yeah, I just want you to know that it does shoulder. Primary action for the deltoid is shoulder abduction. That's all. Don't worry about that's more technical for ortho class. So deltoid muscle in green. Trapezius, remember him? We've gone over him like in every lecture, right? So just refresh your memory on him. In the gym, you're doing shoulder shrugs with dumbbells on your hands. Okay. Retraction, abduction of the scapula. So this is the opposite of the serratus anterior. So sometimes people do a shoulder shrug just straight up like this, or they do this. They kind of bring their scapulas together. So think of it like that, okay? Elevate scapula. So how many of y'all work out or no? No one works out in here? And no one works out? Your brain. It's the most important one. Okay, so all right, so yeah, so it's basically doing the shoulder shrug, your trapezius. Okay. Here's where it's located. It's very broad muscle, superior, middle, distal parts. You've seen this guy before. Rhomboid major and rhomboid minor. So, y'all remember this guy? So know him again. Did you clean the room? Yes. Clean it again. Did you learn your rhomboid? Yes. Learn it again. All right. So know where he's located. Nose innervation action. Rhomboid major. Anatomage. This is with him with no colors on there. Rhomboid minor. He's superior to the muscle. He's over here. It's kind of like someone like put a book on his back and stopped reading, and the rhomboid minor is the bookmark. Okay, there you go. Teres major. Okay, teres major, just like the rhomboid major minor, the minor is superior to it. Major's down here. Okay. Y'all seen this one, right? Okay. Redo it again. Teres major, there he is again. Teres minor. Know your origin, insertion, innervation, and action. So teres minor does external rotation, greater tubercle is the term for an anatomist. We use a term, tuberosity, okay? Okay, Okay, so here's your teres minor muscle. Here's some more of your rotator cuff muscles as well. Remember, supraspinatus is superior to the spinal scapula, infraspinatus is inferior to the spinal scapula. It's in the name. And we'll go from there. Okay, so teres minor, latissimus dorsi. So this guy's pretty broad origin. So he's anchoring off of T7 through T12 and L1 through L5. So basically T7 through L5, the spinous processes, which are directly facing posteriorly. And then this portion here, I'm missing like this part of my iliac crest, but here, iliac crest. You can kind of visualize the origin, okay? So if we say T7 through L5, will that make you understand it better? I know if you see all this stuff here, like stresses you out. Oh my God, this T7 through L5 and your iliac crest. That's the origin, that's the anchor, okay? Then it kind of goes here and wraps underneath and attaches to the anterior part of your humerus, okay? That's why when you're doing your lat pull downs, that's how it's able to work your muscle, okay? This looks like on the muscles, on the anatomage, levator scapulae, neck muscles. You love these. I heard you guys are like, these are great, thanks, right? No? Yes? Favorite. All right, so levator scapulae elevates the scapula, okay? You should have a better idea of the origin and insertion now based on the technique I just taught you guys, okay? Learn the action first and then work your way from there. The anchor and then the insertion, okay? He misses you guys too, levator scapula. He told me. I miss those guys. All right, so rotator cuff muscles, or some patients used to say to me, rotator cuff. I'm like, yes, rotator cuff. Rotator cuff muscles, also known as sits. Okay, so basically you've got your supraspinatus, infraspinatus, teres minor, not major. Teres minor, not major. Okay, which one's in the sits group? Minor. Okay. And then your subscapularis. So these four muscles, they're tendons, the actual tendons where they insert, make the rotator cuff. Okay. The muscles are called rotator cuff muscles. All right. So it's basically a huge congregation of tendinous material that three of those four muscles insert at the greater tuberosity, and the one subscapularis inserts at the lesser. Okay. So if you guys, I know I showed you guys, a few of you guys in the lab, the humerus bony model, and Duke was trying to eat it. I don't know if y'all saw that part. He thought it was a real bone. Like, no, buddy. He got all excited. But he saw the bicipital groove, how deep the canyon is, and he saw a lesser and a greater tuberosity. And then we have like 75 scapular muscle models down there. Those are good to understand the cuffs, okay? All right, so yeah, those muscles basically allow you to do every motion possible in the shoulder. When one of those tendons tears, it's a big problem. So we talked about acromion shape and size. The acromion, if it's sharp at the outer edge, imagine if you had a sharp acromion right here, and you did this a lot. It's basically like a pickaxe picking away at that rotator cuff over and over. And that's why it leads to a chronic supraspinatus tendon rupture. That can happen. It can also happen violently, like a baseball player throwing a 100-mile-an-hour fastball and it tears their rotator cuff. Out here, you're more vulnerable when you're doing exercises, okay? Keeping the elbow in. Let's say you're doing, there's an exercise called shoulder press. Those of you who don't work out, shoulder press, you have dumbbells here, and you do this. I'm very vulnerable here. I'm putting my rotator cuff and joint at compromise. But if I do it here, I'm more stable, I'm more safe, okay? Because I'm closer to my midline and I have more support. So those that have like arthritis in the shoulders or not that strong probably should stay here for a while until they go out here. Yes, Slim.
So, oh wait, so you're saying that it's like, is that like incorrect form, or you just said
No, it's a accommodation or a modification. or a different way to work it that's much more safe. Out here, you're very vulnerable. If I have you guys like hold like a 5 pound dumbbell like in this for like a minute, you're gonna start doing this and start having strain here on the front of your shoulder. If you have it here, you're gonna have to be up a little longer. Your synergistic muscles are stronger when they're closer to the midline of your body. Out here, you're more vulnerable. Have you ever had probably not, but I had to carry like part of my training. I had crazy senseis growing up. They hold buckets of water, and if I faltered, they'd put more water in it. So yeah, I'm calling senseis. Yeah, they're nice guys. Misunderstood, but nice guys. But out here, it was very challenging to keep those water buckets up. But if I had bent my elbows and put them closer, I would have been probably holding a little longer. See what I'm saying? Yeah. So that's what I meant by that. So, but yeah, you're more at risk out there. So, supraspinatus muscle. So this is one of your rotator cuff muscles, your sits muscle. So he does primarily abduction of the shoulder. Notice that where it inserts and it crosses over the spinous scapula, it's going to contract and allow this to happen, okay? But first 15 degrees, so you'll learn some special tests when you take orthopedics. This is going to come, so highlight that and write coming soon to ortho. You'll understand this better in your ortho class, okay? The first 15 degrees, if you're unable to, if someone has a rotator cuff tear, primary supraspinatus tendon, you have them, hey, abduct your arm. Or someone who does not have the problem, we're able to do this fine, no problem. Someone that does will start doing this. They'll lean over and start trying to like launch their shoulder up into the air. Those are your first 15 degrees. So in those first 15 degrees, if someone cannot abduct their shoulder, highly likely they tore their supraspinatus tendon. Okay? Or the arm, the resistance test that you push down test, you'll push down their arm, it just drops. That's a supraspinatus tendon rupture as well, okay? So you'll learn that in ortho class, but I'm just telling you that now so you have an understanding of the importance of it, okay? And your innervation as well, suprascapular nerve. Here's what it looks like here in the model. Can you guys see it? It's this little green thing right there, okay? All right, so this is a CT scan view. Everyone okay? Everyone confused or no? Good? Okay. All right, your infraspinatus is inferior to the spine here, greater tuberosity. So where does the supraspinatus insert? Greater tuberosity or lesser? Greater. Infraspinatus, greater or lesser? Yeah, so you can see the supraspinatus will tuck under the acromion and wrap around the anterior part and attach there. Infraspinatus wraps around there. So this is your actual rotator cuff here, okay? That group of tendons that's attaching there, these are the actual muscles that act on it. So external rotation, so one way to remember is it's the opposite of in. If you go into a building, you have to exit. So infraspinatus does external rotation, do the opposite. That's one way to remember it, because I will have you know the motions for these, okay? Infraspinatus does external rotation, okay? See, since you already had a little bit of this already, it's easier to explain it, right? Now you just have to fine tune it now. So here's another picture of it as well. Be able to identify where it's located on models and on the anatomage, as you all know. There it is again. So teres minor, not major. Teres minor, see here, he is inserting into the greater tuberosity, making the rotator cuff. That's number 3 of the 4 rotator cuff muscles, and its tendon insertions at the greater tuberosity. So teres minor, he does also external rotation, okay? So out of the 3 right now, which one does abduction? Supraspinatus. Which ones do external rotation?
Sarah's minor.
Perfect. Okay. Awesome. I need you guys to learn that. All right. The origin. Does it start to make sense now more as you go? I could sense you guys like, okay, that's what he meant. All right. So more muscles there. Now subscapularis. Now he's on the posterior part of the scapula or the anterior part. Anterior part. He's in the subscapular fossa, which is huge real estate on the anterior part of the scapula. So he's going to insert into the lesser tuberosity. So if he's inserting the lesser tuberosity humerus, if he contracts, what's happening? What's up? Medial rotation or internal rotation. Okay, does that make sense now? So if that stuff is going to start to make sense now for you guys. You understand it that way. Okay, so here's where it's located. So I made this little slide for you guys to understand what's happening here, which each major motion, abduction, adduction, flexion, extension, internal rotation, external rotation, which muscles are responsible for it. Don't worry about the initial 15. That's for orthopedics. We learn that. But for now, I just want you to be concerned with the main motion, okay? Everyone hear me okay in the back? I left the Broadway mic in the office. Sorry, forgot. I hadn't taught you guys in like 3 weeks, so I forgot what that's about. Yeah, so this is a good chart to study off. You can, if you want to add more, like the pictures of the muscles on here, stuff like that, you can. Or just have fun with it, okay? These are your slides. So shoulder movements and the muscles. So as I discussed, elevation, depression, your trapezium muscles, which ones depress the area, protraction, retraction, and these muscles as well. Okay, sounds good. So raise your arms above your head. Everyone do it. Raise your arms above your head. Get a good stretch. All right, so the first one is your supraspinatus, second is your deltoid, third is your serratus anterior. Okay, so that's what's happening there. So that last part you're stretching is your serratus anterior. Okay. All right, that will make sense. Okay. All right. We went over these as well. You have to know them again. They may show up again on the test. You've learned these for a physical diagnosis class, correct? These are very important. Why is that? Cancer, yes. You do not want to miss that. Okay. I know it's like, oh, I have to learn these, but think of how important it is to learn them, and you see a patient that may have it, and you find it. Okay. So here's a little bit of my handiwork. Anyway, so one day I was on call. Anyone know what this is? Is that your index finger? All right, so I think this was a saw incident or something. I can't remember. It was a long time ago. But I was in surgery. I was doing a total knee, and then they called me out of the surgery to go deal with this because thumbs, as I mentioned, are medical important. Yes, but they're medical emergencies. Okay, so yeah. So basically, it literally went down the entire phalanx, distal phalanx, a lot of soft tissue compromise, infection risk. He was right hand dominant. This is right hand. Anyone know what this aluminum sheet is here? It's a nail, yeah. It's a faux nail, basically. I used the suture packet and designed it into a nail. Why am I doing that? That's protection, but what else? Yes, it can grow back. It keep the cuticular layer open. If that does not have a space between it, it'll seal shut, and the person will be able to get a nail to grow again. So he had a nail bed repair. I repaired his nail bed. It was completely macerated. And then I fixated it with 3 nylon sutures, you see there, proximally and distally, to keep that cuticle open, okay, and protect the nail bed repair I just made, okay. And then I kind of stitched the anterior part there. So what do you guys think? Pretty good job there? Yeah. I think it was a saw accident. Thank you. I think he cut his finger in a saw. But yeah, you too can do this if you listen to me.
Wait, Professor.
Professor,
Yes.
Oh, wait, never mind.
Oh, no,
I was in a different order, so I was gonna ask what that one was.
Oh, this one? This is I had already cleaned this one out. This was a tendon maceration, completely obliterated the extensor indicis tendon. Guys, we need to simmer down on the chit chat, please. Yeah, this was a tendon. So you have two extensor indicis tendons. Both of them were basically obliterated here. You can see it's just kind of dangling there. I put the towel underneath to kind of give it some support, but basically the person could not extend their finger at all. I don't remember what happened, but I cleaned it out nicely. So these are things I sent to the surgeons, the hand surgeon, like when I was on call. But hey, man, I just cleaned this out. What do you want to do? You want me to put it on the schedule? Do you want me to not feed them? You want to send it home? I was asking that. Yeah, 6 different hand surgeons are going to use 6 different answers. Trust me. I was like, oh, admit him. We'll do it right now. I'm like, oh, it's 1 in the morning, man. Come on. Anyways, but yeah, that's one thing here. And then this little guy here, this was a surgeon that sent me a picture of the work I did. This guy had a total shoulder done. He had tattoos, and he said, "Awesome job." And I said, "Thank you, sir." I kept it professional. I just knew never be their friends because they'll turn their back on you, stab you. Anyways, yeah. So you can see the detail. You can zoom in if you want. Long incision. I told the anesthesiologist to simmer down and go read a book or something because I was not going to rush this. So yeah, this is closed with thank you, monochrome sutures. Remember? They're like, it's like fishing string. It's like for plastic surgery closures. So this took a little bit of time for me to close, but I had to line up all his designs together because this guy was an avid tattoo guy. As you can see, he's got freaking something on his chest there. I don't know what it is. But yeah, his entire legs are covered in tattoos too. But this is how intricate you have to be your suture closer, okay? Because yes.
Oh, just curiosity. Did you have to consult plastics?
No, I had, because when I worked in trauma, I had worked with plastics as well. So I had known how to make skin grafts, and this is just a simple subcuticular closure, but you have to have the extra level of patience, hand dexterity to kind of do this, and need to command the room. What I mean that is CRNAs, anesthesiologists like to rush their closures a lot, particularly if you're a PA or a student. Ask around when they'll be here next week, the people on rotation. They'll get really mean, like, oh, hurry up, yeah, put in page, I'm gonna wake them up, and you wake them up, you screw this closure up. I'm not, it's on you, not on me. So that's always to tell them, but tell them, hey, sit down, take a break, keep them asleep for me. I gotta close this nicely. But yeah, something like that, you gotta take your time. You can't rush that. Can you all even tell there's an incision there?
No.
Yeah, so that was my craft. I really loved the OR. So, but yeah. So I just thought I'd share some of that stuff with you. It's okay. You can delete these if you want. I don't care. Whatever. All right. Any questions? All right. Okay. So I hate to do this to you, but I gotta get the next lecture started. Okay. All right. So let's take a 4-minute break while I get that one up, and then we'll start the next one, okay? Because it's really crunch time right now, okay? All right? Okay.